All right. Quest Counseling.
Here.
Thank you. ACT Coalition.
Here.
Thank you. Bridge Counseling.
Bridge House, is that?
Well, I have Bridge Counseling. I think I saw David come into the meeting.
David Robeck from Bridge is here.
Oh, great. Thank you, David. New Frontier.
We're here.
Thanks. CASAT, UNR.
Here.
Thank you. Community Counseling Center.
Here.
Thank you. Churchill Community. Oh, excuse me. Oh, I thought I heard somebody start to say something.
I did. Community Counseling Center Las Vegas is here. I didn't know if you meant us or Carson City.
Oh, okay. Thank you. I'll make a note of that.
Thank you.
Thanks. Churchill Community Coalition.
We are here.
Thank you. Join Together Northern Nevada.
Here.
Bristlecone.
Here.
Thank you. Step 2.
Stacy, before you keep going, I'm just realizing you're not getting names of people down, and most minutes have names. I can kind of informally tell you who everyone is, but for your minutes, if you wanted to ensure that you've got everyone's names as well.
Okay. All right. So in that case, I'll read my organization and then the members I'm expecting. Would that be appropriate, Jamie?
Wonderful. Thank you.
Okay. Thanks for pointing that out. All right. So I'm sorry. So Bristlecone, and we'll start here. I have Lena and Peter.
Lena is here.
Oh, Lena. Thank you, Lena. I'll make a note of that. Okay. Step 2, Mari Hutchinson.
This is Mary Hutchinson.
Mary, thank you. Okay. West Care, Leo Megradician, is it?
Correct. Good morning. I'm here.
Thank you. Frontier Community Coalition, Wendy Nelson.
Yes, I'm here.
Thanks, Wendy. Vitality Unlimited, Esther Quillisi.
Here.
Thanks, Esther. Ridge House, Danny or Gina, or both?
Gina.
Gina, thanks, Gina.
Thank you.
And finally, Help of Southern Nevada, Jasmine Troop.
It's Jasmine Cooper.
Oh, Jasmine Cooper. Thank you. We'll make a note of that. All right. Got it. All right. So that is definitely our quorum.
Great. Thank you.
Hello,
So the meeting...
excuse me.
Oh,
I'm
yes.
not here. I'm here representing Accept Reno, Latoya Romero.
Okay. And would you please say your organization name again?
Accept.
Okay. Thank you.
Stacy, this is Esther.
Yes.
I have a very unstable connection.
Oh.
So just so you know, it goes in and out, and then it freezes, and then it says, call me back. Am I supposed to call you back?
That's very frustrating. Sometimes we do suggest that people leave and then re-enter the meeting. That may be helpful if you completely lose connection.
And Esther, this is Jamie. There's the phone number, the call-in audio. It's on the agenda. If your internet connection continues to be unstable, you can just call in the similar to the old SAPTA meeting days where there was the 1-800 number you could call in. Of course, it's not the 775 number, but another suggestion if it doesn't improve.
Okay, thank you.
And chairs, if I may interrupt for a moment, I would like to do some housekeeping. Are you okay with that?
Sure.
Great, thank you. My name is Shannon Bennett. I'm the Health Bureau Chief for the Bureau of Behavioral Health, Wellness, and Prevention, serving as staff for this advisory board. I have a couple things I want to remind you of as this meeting is open meeting law. We would like all board members to be on camera. Everyone else should be off camera unless you are speaking. The chat function has been disabled for this meeting to ensure that we are upholding open meeting law and capturing everything that needs to be stated and kept for record. Public comment is only allowed during public comment opportunities and should not be a discussion. The discussion topic should only be for the board and the staff of the board, which is staff at the Bureau here. So public comment should not be made unless it is a public comment time. And please, before you are speaking, please state your name for the record so we can record proper minutes. Thank you, chairs, for allowing me to go over that housekeeping.
Thank you, Shannon. I think those are all great reminders. So the meeting was called to order at 9:05, and Stacy, I'm just confirming that this was properly agendized and noticed according to the open meeting law.
Yes, it certainly was.
Okay, thank you. And I do not see on this agenda a co-chair report. So I'm not sure, I do have a co-chair report and I'm not sure where you would like me to do that.
Shannon, would that be something you could help me with? I'm not sure where that typically goes in these kinds of meetings.
If it's not on the agenda, I would assume you could do it in public comment would be my thought. We did work through the agenda with the chairs. I'm not sure if that was the intention.
Definitely not intention, just something that we missed. So apologies on that, Jolene.
That's okay. So first I'm going to ask for public comment before I do my co-chair report. So is there any public comment during this time? And please remember that action may not be taken on any matter brought up under this agenda item until scheduled on an agenda at a later meeting. Last chance for public comment. All right, I will go ahead and do my co-chair report. I had the opportunity, my name is Jolene DeLune, sorry for the record, from Quest. I had the opportunity to attend the Improving Community Response Summit in Las Vegas in January, which was put on by the state. There were some really positive connections made between prevention and treatment providers, Medicaid and DPBH, and many other supporting agencies. At the end of the summit, well, actually, many people on this meeting were at that summit, so it's really nice to see all of you again. And at the end of the summit, Director Cody Finney spoke and indicated that if treatment providers needed anything from her, to please reach out, and that her mission is to have DPBH support and encourage our work at every level. So I really appreciate, please make sure you're muted if you're not talking. So I really appreciated that, and I will get back to that in a moment. But basically, the summit was about all of us working together at no matter what our role is, that we all work together, basically to for the end result of that our clients get really incredible evidence-based service from us, and that they get their needs met. This board is about representing and advising the state on prevention and treatment service delivery. I'm sure others would agree that the behavioral health business has become so complex, demanding, insurance-driven, government-driven, and agencies must be all things to all people with a vast array of professional training and expertise. My goal as a co-chair and on the SAPTA advisory board as a member is to improve communication, understanding, and response time between the state and the SOB while helping one another to gain perspective of each other's roles. What the state does is really important, and what all of us do is really important. And I think we need to come together more on that. As a treatment provider, Quest is also a CCBHC, and the demands have never been higher for us. We are tasked with increasing capacity and programming serving more clients with additional specialty populations, and now adding crisis stabilization and support services to our full plate with no extra funding. So Quest, my purpose in bringing this up is that Quest received a NOFO, Notice of Funding Opportunity, back in July of 2022, and we just waited 7 months to get paid for our work that started in July. It was a new child psychiatric program that we started that was so badly needed in our community. We've served 150 children and their families in just 6 months. And I don't know that after going through that process, I would want to apply for any future funding. It felt like Quest was not essential, that our work was being devalued. And I've talked to other agencies who have had the same struggle with reimbursement and feel some of the same frustration. Of course, all of this comes at a time when our encounter rate as a CCBHC was just reduced by 40% in July. That's a huge hit that we took, and I know other agencies took a similar hit. And I'm not the only CCBHC to reconsider our provider type and our CCBHC status. Sometimes we wonder whether or not that is worth it. So, as you know, the cost of doing business with today's grim economy and inflation significantly impedes our ability to turn a profit. We are under a lot of scrutiny. We have a great deal of accountability and responsibility to the state. We submit WITS data. We have certification and site visits constantly, either as a SAPTA certified program or as a CCBHC. We have data extract meetings every 2 weeks. And we do our part and are responsible to SAPTA and the state. And I am just asking that the state be more responsive and accountable to the providers in the ways that I have described. I think after having been through this process of the NOFO, I really do recommend that the state, whether it's SAPTA or the contracts department or whatever it is, they meet with us to determine and learn more about what this process was like, so that we also understand their process and how in the future anyone who applies for a NOFO or any kind of funding would have a more seamless, efficient, and timely process. Thanks for hearing me out on that. And I do plan to reach out to Director Cody Finney to just talk with her about my concerns and the concerns that I've heard from other treatment providers. So I was really glad she extended that opportunity for us.
Jolene, this is David Robick at Bridge. Where do I go to applaud your statement? That was wonderful. You did a really great job.
Just a thumbs up.
And yes, I'm thrilled that the new governor has decided to put everybody from the state back in their offices. So maybe it'll be a little easier for them to work, because I know that's a challenge. But everything you said was correct and understood and supported by Bridge Counseling and our 2 CCBHCs down in the South. And I'm just really proud of you for even putting that out there. And in fact, I think it has become a situation where the state no longer listens to us anyway. Everything seems to be top down. And that's why I didn't even join the January meeting that you were referring to, because there was no representation from us. So anyway, that's a great job. And excuse me for intervening here, but when somebody does a great job, I have to just really applaud. Thanks.
Thank you, David, for your statements. I really appreciate your support. All right. Anything else? Let's move to agenda item 3 then. This is an action item for approving the minutes.
And excuse me, Chair, is it Dalloon? I want to say your last name correct.
Yes,
Dalloon.
Dalloon.
Thank you. Thank you. I've just been informed that we should take a kind of a roll of all of our guests so that we know the names and organizations of everyone.
Thank
you, if we could do that. Sure. So to begin that, I get how is there a better way of doing that? We've got a lot of people here.
Stacy, I can go ahead and read off the names that are on our list, And if there's 2 phone numbers that will, probably one of them are yours, but I'll just go through, and anyone, if I am misspeaking or if whatever Zoom name you have is not correct, please go in and correct me. Does that work for everyone? Okay, Abigail Bailey.
I'm here. DHCFP.
Thank you. Amy Hines Sutherland, I'm guessing. If you could tell us what agency you're with, Amy.
Hi, yes, Nevada Association of Counties. Sorry for the delay on that.
That's okay, thank you. Okay, Antonio Caparelli.
Hi, yes, this is Antonia Caparelli with the state of Nevada.
Ben Trevino.
Good morning. I'm with the Bureau of Behavioral Health, Wellness, and Prevention.
Thank you. Brandy Archuleta.
I'm here with the state of Nevada.
Thank you. Brianne Van Dyne.
Good morning. Brianne Van Dyne with the Bureau of Behavioral Health, Wellness, and Prevention.
Thank you. And Carol.
Jamie, this is David. David, I apologize. Just a point. I keep hearing state of Nevada. That is a big, long thing. So if there were, I'd love to know what they're representing here. Thanks.
Brianne, can you let us know what division, department, the smaller set of letters you're within?
Sure, I mentioned that. It's the State of Nevada Bureau of Behavioral Health, Wellness, and Prevention.
Wonderful. And I know Antonia is also Bureau of BWPH, etc.
Yes, thank you, Jamie Ross. Substance Abuse Treatment Prevention Agency, so SAPTA.
Got it. All right, and it looks like we had Andrea Peterson join us. If you can let us know what agency you're with.
Hi, my name is Andrea Peterson. I'm Executive Director of the Empowered Program.
Thank you. And Carol.
Carol Basagoitia?
It does not have a last name, but you're the only Carol, so it must be you.
Carson City Community Counseling Center.
Fabulous. And can you spell your last name for Stacy?
Yes, B as in boy, ASAGOITIA.
Thank you.
You're
and
welcome.
Shar Frost.
Good morning. I'm Shar Frost. I'm the Statewide Family Network Director for Nevada PEP and the chair of the Clark Regional Behavioral Health Policy Board.
Thank you. And Sherilyn Rarwood.
Sherilyn Rarwood, for the record, Northern Regional Behavioral Health Policy, supporting Carson, Churchill, Douglas, Lyon, and Story.
Thank you, Sherilyn. Christine Lee.
Hi, this is Christine Lee, and I'm with SAPTA.
Thank you. Claudine Boucher.
Hi, this is Claudine Boucher, and I am also with SAPTA.
Apologies. Thank you, Claudine Boucher. Dawn Yohe.
Good morning, Dawn Yohe from the Department of Health and Human Services Director's Office, Fund for Resilient Nevada.
Thank you. And Denise Williams.
Good morning, this is Denise Williams, and I'm with SAPTA.
Thank you. Dorothy Edwards.
Good morning, Dorothy Edwards, for the record, Washoe Regional Behavioral Health Coordinator.
Thank you. And Elise Monroy Marsala.
Good morning, Co-Chair Elise Monroy Marsala with Bells and Case Government Affairs, representing the Psychiatric Association.
Thank you. And Farzad Kamiar.
Yeah, Farzad Kamiar, Psychiatry and Addiction Medicine from Roseman Empowered Program.
Thank you. And Gina Flores O'Toole. She's waving. She's here. Thank you. Hopefully hopefully it's SAPTA, it looks like she may be at a government building. So hopefully someone knows what department she works at.
She's from Ridge House, I believe.
Ridge House.
Yes, I'm sorry. I'm from Ridge House.
Thank you.
Thanks a lot.
And Heather Kuhn.
Here, Heather Kuhn. I'm with the Bureau of Behavioral Health, Wellness, and Prevention.
Thank you. Apologies. And Jamie Webster.
Good morning, Jamie Webster for the record. I'm a health program specialist with the Bureau of Behavioral Health, Wellness, and Prevention.
Thank you. And Jeff Marotta.
Good morning. I'm with Problem Gambling Solutions on behalf of Nevada Problem Gambling Services.
Thank you. And Jenny Bear.
Hey, I'm also with SAPTA, and it's also the Bureau, which is the Bureau that Shannon is the chief of.
Thank you. And Jennifer Tongal.
Good morning, Jennifer Tongal here from SAPTA treatment.
Thank you. Joseph Turner.
Good morning. My name is Joseph Turner. I'm with the DHCFP, Nevada Medicaid.
Thank you. And Joshua Cabral.
Josh Cabral with Rural Nevada Counseling.
Thank you. And Casey Chu.
Casey Chu with New Frontier.
Thank you. Kendall Holcomb.
Kendall Holcomb with the Bureau of Behavioral Wellness and Prevention.
Thank you. And Kimberly Garcia.
I'm Kimberly Garcia with the Bureau of Behavioral Health, Wellness, and Prevention over Problem Gambling Services.
Thank you. And Laura Osland.
I'm Laura Osland, the Executive Director of PACE Coalition covering Elko, Eureka, White Pine counties, and I'm also the chairperson of the Nevada Statewide Coalition Partnership.
Thank you. Lawanda Jones.
Lawanda Jones with SAPTA.
Thank you. Latoria Ramiro.
Latoria Ramiro representing Accept.
Thank you. Oh, apologies. You did already introduce yourself. Apologies. Linda Anderson.
Good morning, Linda Anderson, Nevada Public Health Foundation.
Thank you. Lori Follett.
Good morning, Lori Follett with DHCFP, Nevada Medicaid.
Thank you. And Mari Hutchinson.
Mary Hutchinson, I'm here. I'm with Step 2.
Apologies. I'm trying to skip over all of the folks who've already introduced themselves, but I'm obviously missing a couple of people, so I apologize. And Mark Disselkoon.
Mark Disselkoon, Center for the Application of Substance Abuse Technology at the University of Nevada, Reno.
Perfect. Mark Kruger.
Hi, Mark Kruger, Nevada Attorney General's Office, Bureau of Consumer Protection.
Thank you. Michelle Bennett.
Good morning, Michelle Bennett, Clark County Social Services.
Thank you. Michelle Guerra. Michelle, you're on mute.
Sorry. Hi, good morning. Michelle Guerra, Nevada Behavioral Health, and also a member of the Clark Regional Behavioral Health Policy Board.
Thank you. And Michelle Berry.
Good morning, Michelle Berry, University of Nevada, Reno, CASAT, and the State Opioid Response Project.
Thank you. And Michelle Padden.
Good morning, Michelle Padden, UNR CASAT.
Thank you. Rachel Isherwood.
Good morning, Rachel Isherwood with Bureau of Behavioral Health, Wellness, and Prevention.
Thank you. Roxanne DiCarlo, maybe?
Roxanne DiCarlo with the Empowerment Center.
Thank you. And Sarah Misera.
Sarah Adler, Jamie. Good morning, Sarah Adler with NAMI, Nevada. Sorry, that's my Mercero Adler long name. Apologies.
Thank you. Apology. And I apologize. All of these are shortened. So if you have a name that's longer than like 10 letters, I'm only seeing the first 10 letters. Welcome, Sarah Adler. And Shannon Bennett, of course.
Yes, I'm here. Sorry, were you waiting for me? I'm here. This is Shannon Bennett. I'm the Bureau Chief for the Bureau of Behavioral Health, Wellness, and Prevention.
Wonderful. And Stacy Whitkey, you know yourself. Stephanie Cook.
Stephanie Cook with SAPTA.
Thank you. Tammy Davison.
Tammy Davidson, Rural Nevada Counseling.
Thank you. Tracy Palmer.
Good morning, everybody, Madam Chair. This is Tracy Palmer, Health Program Manager over the Substance Use Prevention, Treatment, and State Opioid Response Teams.
Thank you. Trey Delap.
Good morning, Chair, Trey Delap, Group 6 Partners.
Thank you. Valerie Kawape.
Good morning, Valerie Kwape Haskin, Rural Regional Behavioral Health Coordinator, to present on behalf of the Rural Regional Behavioral Health Policy Board.
Thank you. And Yesenia Fuentes. Yesenia, if you're speaking, we cannot hear you. All right, we've got 2 phone numbers, one ending in 11. How about a phone number ending in 17?
Hi, Kay Villardo, Community Counseling Center in Southern Nevada.
Thank you, Kay Villardo. Appreciate it. And is there anyone I've missed? Anyone who snuck in during roll call? Wonderful. I'll pass it back over to you, Chair DeLune.
Thank you, Jamie. That was quite a task. You did a great job. All right, let's move to the meeting minutes were sent out. So for item number 3, agenda item 3, we'll need to approve the minutes for both October 19th and December 14th, 2022.
Jolene, are you asking for both of those at the same time?
No, let's do one. October 19th first.
Move to approve as presented. David Robeck at Bridge.
Thank you, David.
Leo Mugardichin, I second.
Great. Thank you, Leo. And
so Chairman, this is Esther. I wasn't
yes?
listed present and I wasn't listed absent. So I think I was absent. So why don't you just, otherwise you just kick me out of the whole group, and how sad it is.
So it looks like that needs to be reflected in the minutes. Yes.
Yeah, reflect away, would you?
Thank you, Esther.
Esther, you're in here on the first page.
Yeah, but am I on the list of notables?
Third to the bottom. You're here on October 3rd.
Oh my God. Okay, I missed that. Sorry. I have to read. Okay, so take it back.
Okay, we'll take it back. Is there a motion to approve the December 14th minutes then?
I got a question.
Yes.
Madam Chairman, this is Esther Kulisi. So, Miss Whitkey did a damn good job. I don't know if you're using AI, but okay, so you're using probably not artificial intelligence, but human intelligence. But I want to know, it says that the full conversations are linked or whatever. Can she put in how you link to those conversations?
Okay, this is Stacy Whitkey here for the record. Are you speaking of the notes from October or December?
I don't know, because I don't have them in front of me, but I was just reading through them. December, and it said, you know, you can get the full conversation, but there's no link. And for those of us that really need links, is there a chance to send me a link?
Well, I will certainly look into that for you, Esther. I wasn't aware of linking to a chat necessarily, or you know, somebody's conversation, but I a lot of times will include links for presentations, for instance, and that would more be when I'm thinking about linking to something.
I can't remember how you phrased it.
Okay.
So if you want to call me or email me, I will give, you know, if there's no use going through it here. So thank you.
Yes, sure, I'll do that. And thank you for the compliment.
Stacey,
Yes.
So I noticed that all of these meetings are recorded. And in other OML meetings that I've been a part of, as part of the minutes, they have linked to the recording of this so they can see all our lovely faces in the little Zoom boxes that we're all in right now. So if you could add that to the minutes, and I know other OML meetings do allow that. So
Yeah, yes, certainly. Thank you
you.
for telling me about that. Yes.
Okay, so I think we're still looking for a motion to approve the December 14th minutes, correct?
Jolene, this David, just to clarify, is unless there's any discussion about this, about the first minutes, was there any discussion or corrections on that other than Esther's almost correction before we move on? I don't mean to
Doesn't
ask
sound
the
like
question.
it.
I don't mean to ask the question for you. I just was trying to clarify.
No, you're doing a great job. This is so different from my day job running this meeting. It's not my forte, I got to tell you.
Jolene, I get it. So it sounds like there's none. So if you wanted,
Okay.
I would suggest that you just have them vote separate on those things so it doesn't get
Okay. So we'll just go ahead then and make a motion to, I'm sorry. So all those in favor of approving the October 19th minutes, please say aye.
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 All those opposed? Nay? And any abstentions?
I don't know, do I have to abstain? Because I wasn't there, or can I just say aye?
You can say aye.
Aye.
Okay. That motion's approved then. Let's move on to December 14th.
Move to approve as presented. This is David Robeck.
Thank you.
I'll second
Jasmine
it, Esther
Cooper.
Privacy. Okay, or whoever wants to.
Perfect. So Jasmine, are you making
Yeah,
your?
I can second.
And okay,
Jasmine
great.
Cooper.
Esther's the first, Jasmine's the second. All those in favor of approving those minutes?
Aye.
I have nothing else.
Aye.
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 Any opposed? And any abstentions? Great, thank you. Thanks for all of your help in getting that done. I really appreciate it. All right, item number 4, discussion on last month's Bureau funding presentation, which I was very sad to miss. Shannon Bennett.
Good morning, Chair. My name is Shannon Bennett. I'm the Health Bureau Chief for the Bureau of Behavioral Health, Wellness, and Prevention. I believe I believe Stephanie Cook is on, Tracy Palmer is on. We were aware that there were some questions. We're happy to walk through that. I have the presentation pulled up and can go to any slide that you wish. We can just work through questions if you wish.
Yes, and since I wasn't at that last meeting, Jamie, if there's anything that you need to address with that or please do.
So this is just, if we all remember from the last meeting, SAPTA did an amazing presentation, which you can find in the same place on the website. If you just scroll down to the December 10th meeting, it is linked there, so you can pull it up. But because we were not given the full 72-hour notice, there was multiple agencies that requested that we keep this on the agenda for the next meeting because folks wanted some time to look through and be able to ask appropriate questions. So we are open to that. If you guys have any questions about the robust presentation that SAPTA presented last time.
And chairs, if I may, I did not include a complete analysis in my slides, but I should have, and it was I should have included it. But I did want to verbally tell you that to speak to some of your earlier points about some of our tardiness and getting some of these subawards out and whatnot as well in public comment. Right now, we have about $165 million in the Bureau, and 65% of that is one-time funding. So it's primarily COVID relief funding that we have in one way or another. So I completely understand, and you have every right to be upset with us. That's completely understandable why you feel that way. On our side, we've had to onboard a large amount of staff to be able to kick out the money and to oversee the money appropriately and to train them. I've been in my position for a year today. Actually, it's my anniversary date. And I will tell you that I have spent all of my time working on that. So when we have such a bolus of money that is given to the state, it requires a very large amount of work to manage it, to oversee it, to sub-grant it out to all of you, to help ensure we're spending down appropriately and that the money is being used appropriately. So thank you for bearing with us while we've been working through those pieces. Completely understand it's frustrating. You absolutely have the right to be frustrated. Call me anytime. And Cody Finney is my boss, and you can absolutely call and email her anytime as well. And I gave her a heads up that you guys would do that. So I've been working with a lot of you already in the community about late sub awards and things like that, and am happy to continue to do that as we go through this giant amount of money that we have. It's also important on the flip side of that to state that our normal budget's about $56 million. So in 2025, over the next few years, but ending in 2025, we're going to shrink all the way back down. So we also need to think about that in our program planning.
Rather than a question, I'd just like to make a comment. This is David Robeck at Bridge. I'm still rather disturbed, never heard a word from anybody after last meetings, but about how the SAPTA dollars are being used these days. It seems like it is going to answering services or to NAMI, which doesn't provide treatment, which unless you call it a peer treatment, which you shouldn't be, or it's going to the courts, which moves it over to housing programs where treatment is maybe a peripheral thing. It's very limited, and we end up with those clients afterwards after they graduate from those housing programs. And so just still concerned about that. I don't know that I would, if all that money was moved over to treatment for residential treatment and we had those places to support, that'd be great. And I wouldn't have any problem about it as an outpatient provider, though that is problematic. We still cannot serve any undocumented clients here as adults because SAPTA has decided not to fund that and instead gone with those other funding entities. So I'm just going to make that as a comment for the record and leave it there for now. No answers are expected.
Thank you, David. Any other questions for Shannon on the presentation from last month?
I have one other thing, perhaps, chairs, that I could call your attention to, if I may. In here, in the presentation that's linked, it talks about in the Substance Abuse Prevention and Treatment Agency, because we broke it out into all the different pieces of the Bureau. So for the SAPTA specific, I'm trying to find the slide number so you can look at it. It talks about category 10 and category 11. Those are our match dollars, some of our match dollars for the substance abuse block grant. It's slides 13 and 14. We use all the general fund money that we have in the Bureau serves as match for the substance abuse block grant. And then we work with Medicaid on some other components and things like that as well. But what's important here is that I highly encourage you to look at what is here on slide 13 and 14 and what is in the governor's budget. You can go on Nellis and look in budget account 3170, which is SAPTA's budget account under the Division of Public and Behavioral Health, and look at what the governor's proposed budget is, because there are some cuts there. I don't have all the numbers off the top of my head. Staff may, because we've been looking at this. I would say that you guys are much more powerful at this juncture of where we're at in the budget process than we are to make any changes. So I wanted to call that to your attention as well.
Thank you, Shannon, and thank you for telling us where we could access that information in the slides.
Shannon, this is David Robeck. Very quickly, the reference that you've made for the governor's budget, did you indicate which pages those were or which area that was?
If you go in Nellis, the legislative, I don't know what to call it, but the legislative platform that you can look up all of the budgets in. If you look up budget account 3170 in the Division of Public and Behavioral Health, that's SAPTA's budget account. That's really, we have multiple budget accounts in this bureau, but 3170 is the one that SAPTA is out of.
Okay, thanks, Shannon. That's what I
Of course. So I highly encourage you to go peruse that. The other one that might be of interest is 3200 is problem gambling, 3255 is liquor tax, and 3165 is the crisis account. So those are the four in the bureau. Highly encourage you guys to go poke around and see how those budgets are built.
Shannon, could you repeat those numbers, please?
I sure can, Chair. 3170 is SAPTA's. The mental health block grant's also in there and a bunch of other things. That's the big one. That's the biggie. 3165 is the crisis account. 3200 is problem gambling. And 3255 is liquor tax. So I highly encourage you all to go poke around. And, you know, the state budgeting stuff is a little wonky sometimes, and we're happy to field any questions as you have them about what those numbers mean.
So this is Esther. Since Miss Bennett, you're on the phone, do you go alphabetically about distributing money? Because if I hadn't happened to run into Stephanie Cook, we would have still been about 4 months behind. And I do appreciate the fact that you understand how it is to try and run a business. But when you're hundreds of thousands of dollars in arrears, it ain't easy. So I want to know, since you're asking us our questions, and I do appreciate the opportunity to dialogue with you, how do you distribute the money? Because a V for vitality is at the bottom of the list. Could you invert the alphabet and put V on the top and A on the bottom? Yay, that would be great.
It's Shannon Bennett for the record. I appreciate the question. No, I don't think we necessarily go alphabetically. I think we just create a list and start working through it. And I think you guys all realize that these sub-award documents are tedious and they're a lot of work. I'm not saying we couldn't do better. We can 100% do better. And we're working on business processes to improve our stuff. I think a lot of you are starting to be introduced to Smartsheet, to the portal where you upload your RFRs to get payment. That's decreased our payment time substantially, and we have data. We've been tracking the data to prove all of that. So I want you to hear me when I say, like, we are addressing our business processes, absolutely, and we have improvements to make, absolutely. Some of this, though, is also just the giant amount of money that we have to manage right now. So again, call me, email me, text me. I'm here. Talk to me. Same with Cody. And tell me your concerns, and let's work through them. And thank you for your patience as we get better.
Well, 90 to 120 days is too long for Vitality Unlimited to wait. And so I will assure you that Denise has been very helpful. Stephanie's been very helpful. We have not accessed you. Doesn't mean we won't in the future. So I think, what is a reasonable time, do you think, for us to wait? Because 90 to 120 days is a major strain on us. I think it used to be, Miss Bennett, that you submit and within the next month, we got it. It was just like clockwork. Do you know that we can get federal awards the next day? We submit for the federal award and we get it in the bank truly the next day. It is an amazing thing that the federal government can fund those federal awards so quickly. So again, to you, what, I think, I don't know what reasonable is, but 90 to 120 days is not reasonable.
Is your question about, Shannon Bennett for the record, is your question about the subaward itself or payment, just for clarity?
Payments. Well, I don't know, sometimes the subawards take a long time to get signed. So, and I didn't ask that, but I know that that happens. So it's payment after all.
Payments, 100% should be under 30 days. And all of you guys that are in Smart Sheets are under 130 days. We should have Smart Sheet rolled out to all of the subawards at the Bureau within the next couple months. So I think that's going to help tremendously. What it is on our side, you guys, is it's a tracker, so we can see everything all the time of where everything is at. And we haven't had that, unfortunately, before. So that is rolling, that is in the process. You should be getting payment under 30 days. So that's the answer for the payment one. And if you're not, there's a problem and you should call me.
Okay, will do. I'll call you, call Stephanie, call Denise.
And Shannon, I think this brings up a good point. I know that there are many of us on this call, both prevention and treatment agencies, who are still waiting for signed subawards for October 1 start dates. So we're 4 months and 8 days into a fiscal year. At what point in time should we be looping you in if we are not getting our awards in a timely manner? And in your opinion, is 4 months and 8 days not a timely manner?
Yeah, Shannon Bennett for the record. I will tell you that we actually, we're going to have a competition to see who can get their subawards in the earliest this time when we go into this new state fiscal year. So again, it's the same problem. It's the same problem that we have discussed before. It's all of this money. The amount of subawards that we oversee now has just like exponentially increased, right? So that's what the issue is. And hear this also, that it's not just us. We are one bureau in this giant division that has gotten a giant amount of COVID relief. So we have a grants unit that helps us process all of our grants and our subawards. So the amount of subawards that is actually going through that grant unit has, because it serves the entire division, has dramatically increased. And we've had to staff up across the division throughout COVID to handle all this increase of money. Again, as you guys know, because you all run facilities like this, it's not when you staff up, it's not an instantaneous thing that happens, right? Like you have to train and get good people on board and train and get them to a good state where they're able to produce the work that you need them to produce. So that takes time. Not excusing any of this, but this is just, I want to be transparent, and this is where we're at. Now that being said, absolutely 4 months is too long. I don't like retro subawards at all, and staff know that and staff understand that, but that's just not always our reality. You should have them in a month, really. The retro shouldn't be more than a month behind. That's not where we're at right this second, but that's where we will strive to be in the future.
Thank you, Shannon.
This is David Robeck. I just want to make a statement that is, I think this is a reflection on the state, and the state is not taking care of their business. I'll tell you, as CCBH Bridge just got paid on something we had been waiting for since last July. So, and that's from the state, and it wasn't from this department, but it just kind of goes to show you that I can't say that the state is doing a very good job of listening to the people that are actually providing the services out here, and I think that's the key. So it's not just a one-off, one-person new job or anything like that. It is, I think, almost the attitude of the state that we are just happen to be there, and we better do everything right, but we'll get paid when they decide we're going to get paid. So. That's a challenge. So hopefully things will improve here. And I'm sorry to hear you went through that, Esther, because I know what that's like.
Thank you.
This is Lana from New Frontier, and in a lot of respects, I echo a lot of the things that everybody has said. In December, I got paid for an RFR that was due in September, which was prior to the end of the cycle, the fiscal cycle. So I wasn't sure how one could hang out there until December without being reimbursed. The reimbursement process obviously is determined by when you get your NOGA. And if you don't get your NOGA, you can't bill. So the months go by, and that's the hard part, is trying to float programs that you work really hard at and are continuing to provide services for, and not be able to bill to cover your expenses month to month. Thank you for letting me speak.
Thank you, Lana. I really appreciate, the providers weighing in on that. And thank you, Shannon, for your update and helping us to understand the situation. And congratulations on your 1 year.
Jamie Ross, for the record, another question going back to slide 23, the Partnership for Success or PFS grant. I do see that about 1.6 of the, whatever it is, 2.2 million goes directly to the coalitions. And then there's about 600 that goes to state administrative services. Being as the Partnership for Success grant expires in October 1 of 2023, and the reading of the room, I've not heard for specifically whether or not the state is reapplying for this or they are going to not apply, but the reading of the room seems to have been that the state is not reapplying for these funds. And historically, that $581,000 pays for a significant portion of a lot of projects that everyone in this room cares about, such as the Youth Risk Behavior Survey, some data and evaluation. I'm curious if you could get a breakdown of that $581,000, a rule of whether or not a ruling on whether or not the state will be reapplying for the Partnership for Success grant, and if the answer is no to that question, a plan for continuing to fund those programs.
Tracy, do you want to talk about that?
Sure, yes. This is Tracy Palmer. I'm a health program manager over the substance use prevention, treatment, and state opioid response teams. And Madam Chair Ross, yes, the state does intend to apply for the Partnership for Success grant. I agree 100%. The importance level as to all of the activities and events that the coalitions and our vendors have been able to do in using these funds. And we are currently monitoring because, as you know, it's the end of a 5-year. So we'll be doing an end of the 5-year closeout report. And parallel to that, we are waiting. SAMHSA has indicated that the end of February to the beginning of March, they anticipate to have the application out for people to apply. Hope that helps answer any of the questions that you may have. Oh, and then, sorry, you did mention about 581,000 breakdown. If there is a particular spot on the slide, are you just looking at the overall total that's on slide 23?
I'm looking at the blue piece. Can you tell me what goes into the blue piece?
Okay. So I would respectfully ask that I have the opportunity to go back and break that down for you to give you an actual detail of that particular blue piece on page 23 of the slide.
Thank you, Tracy. Jamie Ross for the record.
Sure.
Okay, any other discussion around that? I think in the interest of time, we have a very big agenda, we should probably move on then to agenda item 5, which is SOAR funding breakdown. Heather Kuhn and Sarah Bacon.
Good morning. Sarah is not here. Can y'all see my screen?
Yes.
Okay. Sarah's not here. She is now working for us part-time. So we are in the process of finding another fiscal person to kind of be my right-hand support system. But I do have Tracy Palmer here that I can tag in just in case. She's an amazing lifeline to have. My name is Heather Kuhn. I am the health program specialist that oversees the state opioid response grant. And as Shannon mentioned before, in the interest of transparency, there were requests for us to really dive into what the SOR grant is paying for. It's a large, over $16 million grant. And so I'm just going to kind of break that down today, what our plan is for the upcoming year. In the interest of time, just so we can focus on that fiscal piece, I'm going to go through some of these slides rather quickly, but the purpose of the state opioid project is to address opioid use and stimulant crisis throughout Nevada by increasing access to treatment, reducing unmet treatment needs, and reducing opioid and stimulus overdose death. Originally, the state opioid response grant was only for the treatment of opioid use disorders. However, a few years ago, SAMHSA expanded that to also include stimulant misuse disorders. We have a number of required activities that we have to do for the grant. One thing about SOAR is the bulk of it is supposed to be going out into the community, out into direct services. We do also have mandates to perform a needs assessment. We also have to complete a naloxone distribution and saturation plan, as well as a comprehensive state strategic plan. But the bulk of SOAR is supposed to go back out to the community. And when I get to the slide that discusses our administrative and data collection caps, we can talk about that into more detail. I did list, some clinical information on some of the models that some of the providers are using, the hub and smoke model. But just because this is a fiscal-oriented presentation, I'm just going to move on.
Heather, I'm not
Yes,
sure
Jamie.
you're not moving the slides. We still see slide 1. So if you are scrolling in slides, we do not see that.
Oh, well, that's fun. Thank you, Jamie. Madam Chair. Ed, could you come here for just a second?
Yeah. Yeah.
Oh, everybody can see?
Yeah.
Okay.
You're good.
Thank you.
It's much bigger. We can see that. Thank you.
You are so welcome. Allowable activities include the use of fentanyl testing strips, medication for opioid use disorder, a whole plethora of things. And if you're more interested in discussing these ideas, I'm sure we could do another clinically focused presentation if you would like. In terms of funding restrictions and limitations, as I mentioned, the purpose of SOAR is really to get SOAR funds back out into the community. We have a 5% administrative cap that is the maximum amount that the state of Nevada can use for infrastructure costs. This year, we also have a 5% cap on data collection efforts. This is the first year that that number changed a little bit. Prior to this year, the data collection cap was at 2%, but still the focus is to get SOAR dollars going out into the community. SOAR began in May of 2018. It was originally the state targeted response, and it eventually transitioned to the state opioid response grant. We're currently ready to go into SOAR 3 year 1. But as we kind of go through the life of the grant, it changes over time, each year building on the goals of prior years and creating that comprehensive system of care for opioid use disorder and stimulant use disorder. So getting into our caps so everyone can see it, you can see the breakdown. I'm just going to go through these slides rather quickly. We do have personnel caps for administration, $111,000. You can see that, but I just wanted to sort of illustrate the amount of money that's meant to be going out into the community. We do have a large chunk of our money that is given to CASAT. They are our partners in this, and they help us with the oversight. We are looking to build up the SOAR unit at the state. We're getting an administrative assistant on Monday, and at the last IFC meeting, we did get approval for a health program manager 3 as well as a management analyst 2. So we're trying to get more staff internally, but our collaboration with CASAT is really essential for making sure we can have oversight.
Quick question here, David
Yes,
Robeck, Bridge Counseling, if you don't mind. Of that $16 million, how many people have we actually treated under SOAR? I know we went the first SOAR funding, and it was a lot of extra work for the limited benefit that we got from it. So we didn't continue. So I'm just kind of curious, and I'm hearing a lot of money going to CASAT and a lot of money into the state and stuff. And it's like, but I thought you had said one of the key things is to get it out into the community for treatment. Maybe I misunderstood.
Yes,
Heather, I can answer that question.
Okay,
this is
thank
Michelle.
you.
Sure. SOAR 1 and SOAR 2 combined provided 3,805 intakes, 1,188 follow-ups, and from the point that Karina presented to you in October, there were still 1,213 clients engaged in treatment.
So Michelle, how much money is, okay. So for $16 million, we have about 1,000 people engaged in treatment. Is that what? I don't understand. This is Esther Quillisi.
That remained engaged in treatment. So that could 3,800 total. So that could have meant that their treatment span has concluded, that they are receiving recovery services, or that they have discharged from treatment, have moved on. But for the total, it was 3,800 clients that we've seen.
For $16 million?
It's not all treatment. There is prevention support services and recovery support services that are being provided.
This is David Robeck.
And the payment of
your numbers also include that, right?
And the numbers also include that, and for paying for naloxone, for purchasing naloxone and the distribution, as well as fentanyl test strips that are being purchased. So that 16 million as a whole is not just direct service treatment. So that 16 million is divided up into additional services that are provided.
So my question, though, is still from October, because I asked that in October, it's in the minutes, is how many people were actually treated with the SOAR grant?
3,800.
Treated,
And
not,
Michelle,
not trained or not under prevention.
Correct. Yes, treated.
and Michelle, is that in the 2-year, is that in the October 1 of 22 to October 1 of 23, or is that in the 21, 22 and 22, 23 years?
That is in the correct, the second part, the 21, 22, 22, 23. But it's SOR 1 and SOR 2.
Thank you.
Sorry, Heather, for the.
Oh, no, thank you so much, Michelle.
And then just for clarification on the dates, it was 2019 to 2022. Sorry.
Okay. So moving into our contractual costs, Cassette does get a little over $13 million to help administer the grant. We also help support the regional behavioral health coordinators. We also have a collaboration with the Department of Welfare and Supportive Services in the Recovery Friendly Workplace, and they partner with Foundation for Recovery. We do also have some data collection elements, and then we also have Carasoft, which is a contract for software that runs our virtual dispensary to help us track how much Narcan we have, when things are expiring, trying to make sure that we distribute that the overdose reversal drug in the most efficient way possible. We do also have subgrants with the CDC Foundation. We contract with them for state staff. We also, this year for SOAR 3, we are going to have more of a prevention focus, and we'll be assisting with the with MTSS, the multi-tiered system of support, beginning in July. And many of our coalitions are also working as distribution sites and also training on Narcan and the use of fentanyl test strips.
Could we get a little bit of clarification? Looks like BRFSS at both UNLV and UNR. Cardinal Health is getting $1 million. Curious about what who the fentanyl test, if you can give us some detail about all of these things.
Okay, sure. Cardinal Health is our provider for the overdose reversal drug. The fentanyl test strip distributor that we work with is Medical Solutions, Inc. The CDC Foundation and Reliable Healthcare are both contract agencies that we work with. The multi-tiered system of support. Michelle, would you like to talk about that a little bit, or maybe Tracy Palmer go into that in a little bit more detail?
Sure. So the multi-tiered system of support is looking at teaching educators how to provide assessments and then provide an implementation into the classroom. What we're looking at in this particular budget is providing support for the implementation of the training that will be coming across the platform. So right now there are 175 schools throughout the state that have implemented some portion of MTSS. Some counties have implemented it a little bit better than others, but looking at how can SOAR come in and align to help promote the platform, as well as place prevention support specialists into the particular communities where MTSS is more prevalent and is like emerging as a promising practice. So more to come. If you would like a formal presentation on MTSS, we can provide that at the next SAPTA advisory board.
That's David Rebecca. I'm a little confused. So the whole budget for this is about $16 million, and of that, $13 million is going to CASAT?
To subaward into the community, correct.
So CASAT is now in the business of doing NOFAs?
Yes.
And how is that overseen? I mean, as I'm just seeing, it seems to me that that's just bounced out of the state. And now I realize that's part of the university, but technically it's not, because that's technically not. It is and it isn't. But so I'm just kind of curious how that oversight is handled for that. If we're passing those funds from the state into CASAT, a nonprofit entity, private one, owned by UNR. So I'm just a little confused how that is being managed and overseen.
So, good morning. This is Tracy Palmer, and I just wanted to help support Heather and Michelle as they walk you through David as the member, and then of course as chairs, that we did break down, and I respectfully thank you for that request, because we can actually show you how we are tracking and overseeing. You are correct. It does appear to be a very large amount. We have the columns there, you can see is the budget amount. And then there's also columns that reflect the administrative cost, the data cost. And so what we have done, and due to the respective Shannon's coming on board, is that we're required now looking at our budgets and breaking out into the different categories and making sure what our vendors, providers are actually spending their funding on. So to your point, and hearing you very loud and clear regarding the treatment elements, and making sure, for example, CASAT is actually going out and disseminating this funding appropriately. Part of our oversight, and it's, I would say, about 7 months in now, where we are asking them to provide us what they're spending on the data, what they're spending on in the distributing the naloxone, fentanyl test strips, where they're actually placing these products, and then of course tracking in our GIPR system that we required by SAMHSA to use. And so we are definitely doing a lot more of the evaluation and oversight from that perspective, and technically making sure of where their dollars are being spent. So it is something that we are diving much deeper into. And I just wanted to share that with you when you asked about the oversight. We are requesting those. It's no longer just a spend plan concept. It's actually, where are the dollars being placed, and how much, and where is it going, and so forth. So I hope that that helps a little bit to explain what we're doing different than what we have done in the past.
Okay, thank you for that. I'm still a little, CASAT oversees SAPTA certifications. They also oversee CCBHC certifications. And so they've got somebody in the field doing that piece, but they're also giving out the funds. And so it almost looks like it's.
And then just to be also transparent about the process, the past notices of funding opportunities that have come out have been joint with the state and CASAT, with SAPTA taking the lead. And so we have assisted in drafting, and then collaboratively with SAPTA and other members of the community reviewed grants, had an objective review panel, and then staffed it with SAPTA staff to determine who would receive funding. And so it is not CASAT identifying organizations to fund directly. It is a collaborative, is collaborative with SAPTA staff.
And are those panels public, of who's on those panels? I'm just looking at this, and just as a state, resident, and we deal with Department of Child and Family Services, who have gotten themselves in serious hot water with federal funding, dollar funding, and have been on an ongoing audit from the feds for years, and slows every bit of funding out of them. I would hate to see us get into those kinds of situations here as well. And this is just one example. I can sit here and just as an observer pick this apart, and I'm going, if I can do that here, what are the feds looking at? You know, what are they looking at the money that they've provided to Nevada and how that's being handled? If they ask deeper questions, are we going to end up with an audit on everything that we get from the federal government?
So the project still has to align with state purchasing guidelines and with how the federal dollars need to be distributed, and with all of the grant practices that the state of Nevada has put into place. And so I think that another layer of that is UNR's Office of Sponsored Projects. So they are also making sure that the organizations that have been determined to be subawarded comply with the guidelines outlined in the grant, with the guidelines issued by the state, and that the program is using the funds appropriately.
And this is Shannon Bennett, for the record. We also, to comply with the Code of Federal Regulations, and we have our own internal policies as well, we do have to conduct site monitors and things like that with our subawardees. So CASAT in this case is our subawardee. So that is how we are ensuring everything is in line, and making sure that everything is appropriate for the grant. And as Tracy mentioned, you know, we have this global budget that the state oversees, which Heather's going through here. So I think all of that is what ties together for the compliance side of it.
Madam Chairman, this is Esther Quillisi. Are we on our agenda? You know, it's almost 10:30 and we are on the agenda. I mean, it took us a half an hour just to do the roll call. Are we going to be able to wrap up before 12 o'clock?
This meeting says until adjournment, so we have the ability to go as late as necessary. So just as a normally, I know we are finished usually by noon, but it does say until adjournment. That's something that we talked about before this meeting. This is a super packed meeting with a lot of dense information.
So, okay, so, you know, I get it. You just said until adjournment, but when we have sensitive schedules, I'm not sure I can just stay on until adjournment. So can we just do whatever it needs to vote on something? Because you're going to lose a quorum here. Sorry.
None of these next items need a voting. These are all informational items.
And Heather, for the record, we are nearing the end of the presentation. I'm wondering if you, I can give both my email and my phone number, and I know you guys have concerns. I can research it prior to our next meeting. We can talk about these concerns. I'm the health program specialist, so I'm lowest on the totem pole, but I would welcome, you know, a chat, a series of chats, to hear where you're coming from. You raise really great points, all of you.
And this is Shannon Bennett for the record too, and same goes here. I mean, we do the Bureau of Behavioral Health, Wellness and Prevention, SAPTA specifically does oversee SOAR. So same goes as the previous conversation as well. Like, doors open. Let's talk about it. Let's talk about your concerns. That's what we're here for.
I appreciate David coming forward and stating this is Esther Quillisi. He states some important points. And, you know, maybe this isn't the forum to give him the complete answers or give me the complete answers, but I appreciate what David did, because this is important that we talk about this. It's long overdue, I think.
Thank you, Esther.
And so Jamie Ross, for the record, I think we should probably go through this. One thing I'm not seeing on here is a breakdown of the 13 million that goes to CASAT. And I think that we may want to be able to see that in a future meeting. So we'll add that to the agenda for the next time. And Michelle Berry, I know that I swear you had done a presentation on the CASAT portion of this, but I went in and pulled everything up for the last 3 meetings and I didn't see it. Am I going crazy? Did you not present? Did you present? Help me.
Well,
I
if I
think what
may,
Heather is talking about is the allocation for SOAR 3, and I presented on the allocation of SOAR 2.
Got it. Thank you.
So, Madam Chair, this is Tracy Palmer, Health Program Manager, and I'd like to just support both Heather and Michelle as we wrap this particular discussion up, and so that Heather is able to kind of finish taking you through her PowerPoint. And then also, just for clarification, you're asking for the state to break down the subaward dollars for CASAD. Are you asking for a breakdown of all of the subawards? And it's something that we would need to wait until it actually is finalized. Just for clarification.
Understood. Thank you so much. And I think this will be a discussion that the chairs can have, and we can request respectfully from SAPTA and or CASAT and or CDC Foundation, etc.
Thank you so much, Madam Chair. All right, Heather, if you are comfortable and ready to go ahead and walk them through the remaining portion of the breakdown budget for SOAR, that'd be great.
Oh, Tracy, we are really nearing the end of the presentation. The next two slides are just really the state's administration costs, including rent, office supplies, travel to different conferences, training. So we are getting to the end there, and from what I'm hearing is there is a lot that SOAR will go over for next meeting.
So Heather, this is Jolene for the record, DeLune, and I guess I'm confused. The agenda item says including who will be funded and how it has changed. I didn't see, is this everything for SOAR 3? I must have missed that if it is.
It is. It does not include CASAT's subrecipients.
Okay. All right.
and I think that this is David at Bridge again. I think that's really a key thing too, because it's gone one layer away. And also, did CASAT have to bid for that, or was that something the state just decided to award it to because they're used to them?
Michelle?
Sure.
Hi, this is Tracy.
I am not aware.
Hey, Madam Chair and Ross and David, to your point, Angeline, just for clarification, yes, this is for the state opioid response 3. We call it SOAR 3 in this particular application year. And there was some continuation activities, and there's some data application that is also an activity that we have with CASAT. So it is something that we did not want to break the form of consistency. It also is part of our collection. So to your point, it is something that we had awarded to CASAT based on what was already set in place. And it was something that, we need to carry forward and oversee. So Heather, please put your sound on, your mic on mute. And then I know Heather is done with her presentation. And David, to your point, I hear what you're saying in the sense of it is one step removed. And so, and that's why I had asked Chair Ross, the breakdown for not just CASAT, but also for all the other subawardees once they are awarded, if that's what she was asking. Because it sounds like you want to see the next step of who all is awarded and then what they're being asked to do and what's their specialty area. I'm going to stop there, and I see Michelle has her hand up to help support and answer your question, David.
Sure. CASAT is also a vendor on the master service agreement list for the state of Nevada. So we've already been pre-vetted, and any state entity can come in and ask us if there are certain projects that we would like to work on. And in this case, this is one of the projects that they have asked if we wanted to assist with.
No, I understand those things. I'm just
David, just to add to that.
13 out of 16 million is not a small amount, and 13 million for any agency to be managing is a substantial amount. So again, I'm asking that as much as a state citizen as I am an agency CEO. So Mark.
Thank you for that. And I think right now, in respectful to other folks, this is Tracy Palmer, Health Program Manager. And I think, would it be in the next SAB, David, would it be appropriate, and would you guys request maybe a presentation that actually shows and breaks out CASAT's form or their organizational format, so that we can make sure, because there is, you know, a section that is for certification, there's a section for other activities that they do, and maybe that would also help understand where the dollars are going as well. So it's breaking that down.
So Ms. Palmer, this is Esther Quillisi, and for the record, and you too, Ms. Berry, I never doubt the honesty of the people controlling these programs. I have to be explicit, but when I concur with David, it is nebulous, and we just like it was like a lot of smoke for me. So, but I need to make that statement that there is never a doubt in my mind about the people's honesty who are running all these programs. And so, but I think David's right. We just need a little more information. It's just kind of it was brought up in this forum, and I think it's a good thing to do some clarification. Thank you.
No, absolutely. And I'm happy to prepare a presentation that outlines the allocation and how it's being distributed. But I think it's also important to note that CASAT SOAR 3 award is not formally executed yet, so no sub-awardees have been identified. But I will go through the entire process, talk about the categories, etc., at the next SAPTA advisory board. Thank you.
Thank you, Michelle. We are going to move on to the opioid settlement dollars update by Don Yohe, the clinical program planner.
Good morning. Well,
good morning,
yeah,
Don.
It's still morning. How are you guys? Let me just share my screen real quick. Today with me, I have Mark Kruger, the Chief Deputy Attorney General. We're going to be talking about, I'm Don Yohe, I'm a clinical program planner 3 with the Department of Health and Human Services over our Fund for Resilient Nevada, which are our opioid recovery funds. So we're just going to be going through from kind of start to finish because it's been a long year. I'm going to just start my presentation would be helpful. These are some of the things we're going to be talking about today. Review of the opioid litigation, the opioid settlements, allocation agreement, the needs assessment, state plan, our proposed allocation, and some conclusion and questions. And if you guys could hold all of your questions until the end, we would appreciate it. I'm going to hand over the first section to Mark.
Good morning, Mark Kruger. For the record, I'm with the Attorney General's Office, State of Nevada, Bureau of Consumer Protection. We are primarily handling the opioids litigation on behalf of the state. As Don Yohe just informed you, we're going to take you through kind of how that litigation has proceeded and the settlements that have resulted so far. When we get through that, and then we'll get into the Resilient Fund for Nevada and move on. Don is correct. It'd probably be better to hold your questions just because I think we might answer a lot of them as we go through this. And then also in the interest of time, we'll get through it and then we can have a robust discussion if necessary. Okay, so to begin with, one of the things that the state and pretty much every state has been very, very cautious about is they didn't want a big tobacco type settlement and handle it in the same way that tobacco was handled. So they wanted to ensure that any settlements, the money that was recovered would go to address and abate the harms that have occurred from the opioid epidemic. So we're going to take you through the different areas of law, how that happened and how that came to be and why it's emphasized in that manner. The whole process itself is transparent. We came up with a very equitable and fair way to allocate funds that were recovered through every litigating county and city, in fact, every county in Nevada, as well as the state. So why don't we go ahead and click on to the next slide. Thanks, Don. So to begin with, SB 390, which is now codified in law, and we're going to go over that particular provision in a minute, started out with principles of how we should look at spending the opioid recoveries. The principles came from a Johns Hopkins study in 2021, and SB 390 actually, which passed last legislative session, 2021, is actually model legislation that was discussed at universities throughout the country and is being stood up as something that other states should look to in adopting legislation on how to spend opioid recoveries. The idea and principles behind it are spending money to save lives, use evidence to guide that spending, invest in youth prevention, focus on racial equity, and develop a fair and transparent process for deciding how to spend the funding. Very simple, all with some overlap. Next slide, please. Okay, so how do you fairly and equitably allocate that money that's recovered and ensure that you get the maximum amount under the settlements? Well, that's where we came up with this document called the One Nevada Agreement on Allocation of Opioid Recoveries. In this agreement, all of the signatories, which includes the state, every county in Nevada, and every litigating city or district, signed this agreement, and all of the recoveries, they agreed in the agreement, as well as the settlements order itself, state that the recoveries have to be used to remediate the harms, impact, and risk caused by the opioid epidemic to the state of Nevada and its residents. So basically abatement of this epidemic and crisis that we're in. The uses were adopted through SB 390 and codified in NRS 433.712 through NRS 733.744. You can review those. In addition to that, each settlement has its own uses, and the state of Nevada Department of Health and Human Services actually created a needs assessment and state plan. I'm going to talk about that a little bit more in a few minutes. Suffice it to say, the agreement itself, the One Nevada Agreement, allows money to be allocated to all of the signatories. And I think we have another slide that goes into that. So what happens is, because the Attorney General's office is the lead litigator, that's a common legal term of art, meaning that there's a collective group of counties, cities, and of course the state that have current and ongoing opioids litigation. We are out front. Many of the counties and cities cases are in what we call a stayed status. So as we move forward, we receive settlement to maximize the amount of money we get in any particular settlement. The defendants want to have all of the counties and cities that are litigating into that settlement. We do that through this One Nevada Agreement. When the funds come in, the lead litigator costs are removed, and then the amount of money is allocated pursuant to that agreement. I won't go into the actual numbers and how it works, because you guys can read that agreement. It's all on the Attorney General website. And you can, if you have any additional questions, you can always reach out to me. There is a requirement that each county reports on the use and spending of their money so that we can ensure that we're within the court settlements orders, as well as within the confines of the agreement itself, and now the law that has passed. And the money then that is allocated to the state of Nevada, just the state's portion, is then deposited in the Fund for Resilient Nevada. The Fund for Resilient Nevada was established by SB 390, and it is where that money is housed in order for Department of Health and Human Services to determine what uses it's spent on. They do that through the needs assessment and state plan that they created, which must be updated at least every 4 years. Obviously, needs change in the various geographic locations of our state in order to, effectively eradicate this epidemic. Next slide, please. So legislation I've been citing to is listed here. It does a few things, including establishing the Fund for Resilient Nevada, very important component. Creating an advisory committee for Resilient Nevada. This ACORN committee is important for helping the Department of Health and Human Services create the needs assessment and state plan. And it's also a public body, which means it's very transparent of how that plan was created. I talked about the needs assessment and the plan, and it also establishes a reporting requirement. And that reporting requirement does go to the legislature, and they can then look at it to make sure that things are being spent in a very transparent manner. Next slide, please. So we talked about the Fund for Resilient Nevada. Payments go in, and then the payments go out have to be used for restricted uses of abatement of the opioid epidemic. Go on, next slide, please. All right, this is a chart. I don't know that you guys can see it very well, but hopefully you can. Basically, this chart represents the opioid settlements and the dollars that have been received from bankruptcies, opioid bankruptcies. It represents actual monies that have been received, and it represents estimated monies that will be received through the settlements that have been entered. On the left, the first column are the settlement or bankruptcy name, the estimated payment year or actual, and then the estimated payment month or actual. Then the fourth column is the actual dollar amount that we received. As you can see that by 2038, we will have received $288 million in some additional money. And then you can see how costs were removed. In this case, since the One Nevada agreement, there were $3 million in cost. Then it gives you the next column is the total amount to be allocated, what the attorney's fees came off with. The important thing to remember about attorney's fees is that every contract that each signatory to the agreement entered into with a private counsel may have a different amount. The total allocation after the fees, and you can see that $237 million will be by 2038 at this point in time received. Next slide, please. So what we are concerned about with the state is the deposits into the Resilient Fund for Nevada. You will see that this slide represents what the actual net deposits were or will be into the Resilient Fund for Nevada, so that the Department of Health and Human Services can start deciding how it wants to prioritize funding under the state plan, given how much money they're going to be getting. The only exception to this, or difference between this slide and the first slide, is that you'll see that first settlement name McKinsey. That was prior to the One Nevada agreement, and no other county or city had contemplated suing McKinsey. So that predated the One Nevada agreement and is why it's exceptional. With that, however, the state on the very bottom asterisk had to carry the lion's share of the cost in the front. So that's the only difference there. As you can see, everything else, those are the actual deposits. By 2030, the state should see $122 million for money to be used to abate this crisis. We're not done yet. We have other defendants, and we're continuing to move forward with our litigation, which has a current trial date of May 1st, 2023. Next slide, please. I'm going to go ahead and turn it over to Dawn now to talk a little bit about the ACORN and some other comments that she has in the next few slides. Thanks, Dawn.
Thanks, Mark. This is Dawn Yowie for the record. Part of the legislation, like Mark talked about earlier, was the development of the Advisory Committee for Resilient Nevada, also known as the ACORN. Some of the members are on the ACORN at this time. It's composed of members who range from subject matter experts in their fields to consumers or family members who have been affected by the opioid epidemic. Their primary goal was to prioritize recommendations based on the needs assessment in a report to the director for the potential allocation of funds. This report is due on every even numbered year by June 30th. Moving into the statewide needs assessment, there was requirements while we were creating the needs assessment. We did contract with Mercer to assist with this. They looked over, I want to say, 130 different documents to be able to pull information from. We did have to use the damages report in the opioid litigation. We had to do community-based participatory research. And then we did do outreach to other governmental agencies that interact with groups impacted, as well as we got input and advisement from the committee and other sources, including public meetings and regional, local, and tribal communities. The statewide plan, as that was developed, we realized that it would be more beneficial to have the document as one because we were pulling a lot of information from the needs assessment into the statewide plan, and it was just more robust to make it one complete document and add the state plan and potential allocations within the needs assessment. So this must be, like Mark talked about earlier, the statewide plan must be updated every 4 years, and then on or before January 31st of each year, the department needs to transmit a report concerning all of the findings, recommendations, and monies expended. And so that goes to all of these individuals below. The entire document can be found here. That's linked on the FRN ACRN website. Going into the statewide plan, just to walk you through it, here's a section breakdown. Sections 3 through 6 comprise the needs assessment. Sections 4 and 5 present the opioid impact and currently available systems, as well as the corresponding gaps. The gaps identified in sections 4 and 5 informed each of the recommendations within section 6. Section 7 provides the statewide plan, which includes the goals, strategies, objectives, and activities developed from the recommendations and stakeholder feedback that may be funded through the Fund for Resilient Nevada and other funding sources. And then Section 8 offers details on the next steps for further detailing activities in the statewide plan and allocation proposals. There are appendices, and here's the breakdown of those as well. We have data sources in there, reference documents, prior work towards Johns Hopkins best practice recommendations, additional data that was used, approved uses for opioid remediation, as well as our policies and procedures for administering the fund. This is in the appendices, but I thought I would bring it out because this has been a question asked across the board. What can we use the funds for? So all of this corresponds with the legislation that Mark talked about, but I wanted to put it in here separately because this is per Schedule B of the National Opioid Abatement Trust 2 distribution process. So treatment of opioid use disorder, support people in treatment and recovery, connect people who need help to the help they need, address the needs of criminal justice involved persons, address the needs of pregnant or parenting women and their families, including babies with neonatal abstinence syndrome, prevent overprescribing and ensure appropriate prescribing and dispensing of opioids, prevent misuse of opioids, prevent overdose deaths and other harms, first responders, leadership planning, coordination, training, as well as research. This slide goes through some of the goals that you will see in the statewide plan. So this is the proposed budget allocation for the statewide plan. This is just the first go at this. So this doesn't mean these are the only dollars that are ever going to be spent in these categories. And actually these numbers have already changed since we completed the plan. So these are the goals that you will see, the high level goals. And then under each of these goals will be strategies, objectives, as well as activities that relate to the needs assessment. So goal 1 is to ensure local programs have the capacity to implement recommendations effectively and sustainably. There's no point in raising up programs that cannot be sustainable. Goal 2 is the prevention and the misuse of opioids. Goal 3 is to reduce harm related to opioids. Goal 4 is provide behavioral health treatment. Goal 5 is to implement recovery communities across Nevada. Goal 6 is to provide opioid prevention and treatment consistently across the criminal justice and public safety systems. And then goal 7 is to provide high quality and robust data and accessible, timely reporting. Funding. So per this NRS, the statewide plan may allocate funds to other statewide projects to address the impact of opioid use disorder and other substance use disorder. This can be done through a regular budget allocation process. And then we are also able to provide grants to regional, local, or tribal governments and private sector organizations whose work relates to opioid use disorder or other substance use disorder, as long as opioids are primary. We do have an administrative cap and no indirect, because a lot of these dollars are supposed to be going out to the communities to make sure we abate the opioid epidemic. To be eligible for the Funds for Resilient Nevada, counties, regions, and tribes must create a needs assessment for the legislation, including community outreach to create a plan for combating the opioid epidemic and setting priorities for funding, as well as having a plan for intended uses. And then also ensuring accountability. So to ensure fiscal accountability, existing programs and funding sources were and continue to be identified and evaluated. We are currently doing fund mapping. Once all of the awards are executed with all of the programs, we're going to be putting those numbers into a document so that we understand, okay, harm reduction. The Fund for Resilient Nevada says that they're going to be allocating $140,000 to harm reduction. Well, that sounds like a very small amount of money. So where's the rest of the money coming from? So that is a bigger document in the future that we are trying to provide to everybody. We have a pretty good estimate right now, but that is something we want to be able to be transparent about and show the communities. Like I said, as part of this review, all money in the state is being considered opioid dollars while we're doing these processes. All money recovered or anticipated to be recovered by county, local, or tribal government agencies through judgment, settlements, or bankruptcies resulting from litigation concerning the manufacturers, distribution, sale, or the marketing of opioids, and the programs currently existing in each geographic region of the state to address opioid use disorder and other substance use disorder are being analyzed. I know that was a lot of information for you guys, so do you have any questions?
Dawn and Mark, thank you so much for presenting that. That is a ton of information that I'm still working to digest. And I think that's true for most people. This is the first time seeing most of that. So I appreciate the thorough explanation.
Jolene, this is David.
Hi, David.
Oh, sorry. Don't mean to jump in there. One, it's interesting. We didn't get any of the documents that have the details of the money. We'd sure like to get copies of that if that's possible, because that's rather significant. I'm scrambling trying to get percentages out of here, and it looks like based on the first few years and the first few years of funding on this presentation, it looks like only less than 10% of it's going to actual treatment, which concerns me quite a bit. and overall, you know, that right now, and I know that's going to change, Don. So I'm not going to hold you to those numbers that you have listed here, but the reality is that's like 2% of all the funding that the state received, and I don't want to see it going outside of treatment. And CCBHCs can't be just expected to use our PPS rate to do things. As you heard Jolene say, it's gone down quite a bit and doesn't necessarily cover all the things it should be covering. The other thing too, that since we have a Deputy Attorney General here, I don't know if you're aware, you know, Bridge Counseling for One was subpoenaed under the Walmart et al. Lawsuit before the state decided to go and you know, with a larger national agreement on that. But it cost us many thousands of dollars that we're not getting reimbursed for, because we had to hire an attorney. It took hours and hours and hours of work just to get some of the documentation that they were requiring, and never heard a word from the Attorney General's office. And I'm sure you're aware of who they subpoena when you're in those lawsuits. So I'm just kind of curious if there's any suggestion or conversation about how to maybe make some of the agencies whole that had to go through that extra work and cost us. You know, we're nonprofit agencies. We're, you know, basically a private company that's a nonprofit, and we have limited resources, and that is not in our budget. So I'm just kind of curious if you have any feedback on that.
Well, David, I can speak to that just shortly. You know, first of all, you know, I can understand being a nonprofit that, you know, any kind of subpoena in a large complex litigation would impact your agency. Unfortunately, the restricted use on these dollars is so restricted that it doesn't go. It's not an allowable use to reimburse or compensate anybody. We don't necessarily know who gets subpoenaed. So unless someone tells us they've received a subpoena, we only know that when the state, people we represent, we're not allowed, the Attorney General's office is prohibited by law from providing private organizations, nonprofits, or individuals legal advice. So there's been a lot of talk about, you know, people wanting to get certain amounts of recoveries. And unfortunately, we have no control over that. The control has been through the settlements themselves and the court orders that have entered into the actual use of that money. So I hear you. I feel your pain. Unfortunately, we can't provide any relief.
Okay, you can't provide relief certainly out of the agreements that you reach, but the Attorney General's office decides who they actually sue and who they're going to go forward with, and you certainly make sure that you are paying your attorneys when you're using outside counsel for those things. So I would think the Attorney General's office should at least consider making some of the agencies whole or bringing. See, the problem is we're not a new startup agency. We're 51 years old. And when they went back as far as they did, and I don't know the number of years offhand, it was substantial amount of work here. So just something maybe to bring back to your boss. Thanks.
And this is Dawn. David, going back to your other question about the percentage of funding, we actually did internally like an 18-year budget, because we wanted to be able to identify how much money would be appropriate kind of per year to push out into the communities. It came out to be something very small, like $6.5 million. So really, we're working this next couple of years, building the infrastructure of the state, making sure all of these programs either are at capacity or have that sustainability piece there. And then really looking forward to pushing more dollars out towards, like you said, treatment, criminal justice. We haven't identified how much needs to go there yet. We haven't identified, you know, so this is, even though we're just going to be officially redoing the state plan every 4 years, it is a working process. It is a working document.
So, Madam Chairman, Dawn, what is a recovery community? Some of the language is so arcane in what you just presented. I was just curious, like that caught my eye. What is a recovery community?
They're looking at the social determinants of health in that area. And so if you go into the state plan, it goes into a little bit more detail of what they're talking about when they're saying recovery communities right there.
Thank you, Dawn.
Thank
David, I wanted to echo what you said. Quest spent a huge amount of time and money on the lawsuit too, in defending, you know, what we had done with opioid clients seeking treatment for opioid use and whatnot. And not only my time to dig up all the documents, but the attorney fees. So we were in the same boat as you are, and it was very unfortunate. But I think this, I look forward to hearing more about this and really looking into this more. And I'm sure that we will have questions down the road for you, Dawn, and the Attorney General's office as to how all of this will be dealt with. So thank you so much. And I want to move on. We are actually going to move on to item number 7, but we've made a decision with the regarding item number 8 with the behavioral health policy boards. They've all been very kind and flexible to commit to come to our next meeting in 2 months to present on the policy boards and the BDRs. And so we will table that, okay? And I just thank every one of you who's been chatting with Jamie and myself for being willing to postpone your presentations that you worked really hard on. I apologize for that.
Jolene,
Well,
this
wait
is
a
David.
minute.
Yeah, I'm sorry.
Hold it. Go ahead, David.
Okay,
I don't know who is tabling what. We never said anything out here.
So Jamie and I, as the chairs, have reached out to just the regional behavior policy boards to see, because of the time issue right now, to see if they could speak in 2 months at the next meeting, unless you are all up for going until we go.
Well, I am curious, Jolene, this is David Rebecca Bridge. If any of the policy boards are doing a presentation of what they have submitted to the legislature that is maybe going to be acted upon before the next board meeting 2 months from now. And so it might, not that our input would be of any value or even received at this point, but I'm just kind of curious if there's anything that was going to be completed in the legislature during the next 2 months prior to our next board meeting. So just a thought.
So we can, if everyone is, I know there are time constraints, and I don't know that everyone really allowed, you know, up till 12:30 or 1 o'clock for this meeting. But looking at what's left, that's kind of my gauge of what it would take. So do you want to, put this to a discussion?
Well, Jolene, I'm sorry. I'm not trying to suggest we do anything. I think that the amount of information we have today is well beyond what a typical board meeting should have. And so, and that's not a negative to you guys at all. We're trying to pack as much information in because we've missed a board meeting before and we're trying to catch up and things like that. And we have new staff, et cetera. So I'm just, I don't know, it's a little frustrating because of now we have things that might be timely and they're not going to be presented, but I too probably am not going to be able to stay the whole thing if we're going to 12:30, 1 o'clock. So
Dorothy has her hand up.
Chair, if I could, one option that you may have is to schedule an hour and a half in a couple weeks to hear the rest of them, because I do think those BDR discussions were intentionally put at this February meeting to make sure that the board was aware of the regional board's work that they're working on right now, with session starting here a couple days ago. And I think problem gambling too.
I definitely was going to move problem gambling, if that's okay, but if you guys are all up for it, then we will hear from the boards. I see that Dorothy Edwards has her hand up, and she is on one of the boards. Go ahead, Dorothy.
Good morning. Good morning, Chair, Vice Chair, and Board. I'm Dorothy Edwards, for the record, Washoe Regional Behavioral Health Coordinator. All of the coordinators speaking on, we've been chatting amongst ourselves. We do have presentations. We were asked to be kept to a pretty tight time frame. Having said that, one of us is scheduled, that's actually the Washoe Board, to present to the first committee this month. No action is taken on those presentations. So, you know, there's certainly time to present and question. I would be happy, and I'm sure the other coordinators would be, to also submit to the board a summary document, PowerPoint. So at the very least, you can have that to review. I can't speak for them. I'm certainly willing to come back as Shannon Bennett suggested, and for a special presentation if you want. But just wanted to throw that out there. Thanks.
Thank you so much, Dorothy. Michelle?
Yes, thank you, Madam Chair. The Rural Policy Board is also meeting tomorrow, and in looking at their agenda, all of the regional behavioral health coordinators will be presenting on the legislation that they're proposing. So that is happening starting at noon tomorrow.
Jamie, how would you like to handle this? Do you want to go ahead and then just move forward with some of the presentations?
I think Valerie Kwape's got her hand up, so let's hear from her. But yes, I'm fine with that. If you guys are willing to go the distance, I absolutely am as well.
Okay.
But Valerie?
Valerie Haskin for the record. Point of clarification, the board's legislative subcommittee meeting, which was discussed or mentioned by Michelle Berry, is actually Friday, and that is at noon. And that information is posted on the All Boards website.
Okay, so is Lori Follette still on the meeting?
I'm
She
here,
was.
Jolene.
There she is.
Lori, I would like to propose then maybe that we hear from the regional, the behavioral policy boards. Would you be comfortable moving your presentation to the next meeting?
I'm totally fine with doing whatever works for you, Jolene.
You're so kind. Are the other members fine with that decision to move Lori's presentation? I'm seeing some nods. Okay, thank you very much. I really appreciate your flexibility, Lori.
Okay, Jolene, I'm going to go ahead and drop though. Just if you're not
Okay.
going to need me, I have another meeting to get to.
Okay, thank you so
Thank
much,
you.
Lori. Dorothy, your hand is still up.
I'm sorry. I will take it down.
Okay, that's okay. So let's move to agenda item 8 then and hear from all the wonderful work that the policy boards have going on. We'll start with Sherilyn Rawwood from the Northern Regional Policy Board.
All right, thank you. I'm gonna, well, no, let's see. Attempt to share my screen. All right. Can you all see my screen?
Yes.
Okay.
Thank you.
I don't know. I'm not used to Teams. I apologize. We use Zoom a lot. So good morning, SAPTA Advisory Chair, Vice Chair, Board, community partners, and community members. Thank you for this opportunity to present on the Northern Regional Behavioral Health Policy Board Bill AB 9, which revises provisions governing regional behavioral health policy boards. And I am the Northern Regional Behavioral Health Coordinator, and Taylor Allison is my chair. This is just a snapshot of my board members. Just a reminder that the boards were formed in Assembly Bill 366 of the 2017 legislature to really advise Commission on Behavioral Health, the Department of Health and Human Services, and the Division of Public and Behavioral Health on behavioral issues experienced in each region's communities. In 2019, the Nevada Legislature revised those duties and composition of each board and expanded to 5 regions. And part of our duties within each region is that they were allocated 1 bill draft request to the Nevada Legislative session. And this presentation will provide that overview. So this is a map of the behavioral health regions. As you can see, there are 5. They're kind of broken up in community regions. And the northern region that I support consists of the Carson City, Churchill, Douglas, Lyon, and Story counties. This really kind of gives an overview of what each policy board does now with the way that the legislation is written. And I've added Senator Titus's quote that she made a couple of meetings ago when we were all meeting, and it really was to look at what and why were the boards created, and really go back to the basics of that why. And so this just kind of explains all the board duties that they're required to do every year. So when we're looking at the 2022 board priorities, after several strategic planning workshops, we really kind of fine-tuned what board priorities for 2022. And it really focused on the regional board infrastructure, affordable and supportive housing and other social determinants of health, behavioral health workforce and the capability of treating all ages, development of sustainable regional crisis response systems that integrates existing local crisis stabilizations, jail diversion programs, and reentry resources, increase access to treatment in all levels of care, and develop services to support continuity of care. While the Northern Board recognized that not all of the board's priorities required legislative solutions, the regional coordinator chair and members of the board work really closely with DHHS to provide recommendations and identify solutions to achieve greater outcomes with our priorities. The two areas that continue to rise to the top for proposed policy solutions were regional infrastructure and workforce, because without those two, our region does not have the foundation to improve other priority areas. The regional infrastructure strategies identified in the Northern Board's plans were then expanded on to explore the regional behavioral health authority concepts and to potentially increase system efficiency and focus on serving individuals in their communities, and adding that sustaining the regional behavioral health coordinators is critical to Nevada's behavioral health system and to the regional policy boards, as well as sustaining the necessary support positions. While you will see that the board has collectively removed a lot of that authority language since the first draft, the board has moved to work on language that is enabling, moving the state closer to that authority language, and really working on solidifying that. The board started this by adding more duties for the board, plus adding staffing positions for the completion of OML duties, data collection, grant funding, building towards the capacity of a regional behavioral health authority, and really thinking of future. And during the interim, we really did a lot of research on the Behavioral Health Authority and what states had them, how they were kind of working in each state. And we went back to a couple of reports that were written in 2013 and 2014, which I've showed here. And really, when we read those documents and really researched those documents, we are no closer to really determining that we have filled and completed all those gaps and barriers that were in 2013, 2014. We still have a lot of those barriers and gaps that are still plaguing Nevada as a state. As the board really began to look at the number of boards, committees, subcommittees, coalitions, consortia, boards really became to look at how are we really working together, and how are the gatherings of all of these boards and committees and work groups communicating? What are they working on? What other strategic plans consisted of? And this is the spider web of many of the meetings that we could discover, and how most are really not connected in any way. Working towards that authority language is really the first step towards working on an infrastructure solution and really bringing a lot of these boards and committees together. We also, the board also considered how COVID pandemic has increased demand for behavioral health services and exacerbated gaps and inefficiency in our state system capacity. Having the ability to have insight into how Nevada has or has not recovered from COVID concerning behavioral health care is crucial in understanding how moving forward looks in Nevada. So the proposed solution for building infrastructure will aid in moving closer to that regional authority model, as well as sustain the coordinated positions and really give a robust duties to the board and more skin in the game, all while monitoring the duplicated efforts throughout each behavioral health region by adding these duties. So you can kind of see what some of those duties are going to be broken down to, and I'm going to explain those individually. So first, the bill allows the policy board to employ staff such as the regional behavioral health coordinators to support the regional coordination of behavioral health services and supports the board's legislative duties. hire an administrative assistant to really help keeping with OML and staying aligned with that statute, as well as fund a data analysis staff to support the request for in real-time data. And we know that's really a struggle with the state, is keeping track of our data and making sure that it's current. The coordinator position listed above already exist, and we are funded by the Division of Public and Behavioral Health. This language really creates that more formal relationship between the coordinators and boards. On my board, as well as the rural region board, in the first part of the funding cycle, submitted a letter to the state on our funding issues. We too have just received our funding, so we're kind of in that same boat. This also allows for the sustainability of the regional coordinator positions that really play a pivotal role in Nevada's communities. Notable accomplishments of the regional behavioral health coordinators include supporting the regional MOST teams, FAST teams, CIT programs that exist in a lot of our communities, supporting millions of dollars in federal grants coming into the region, such as the recent $5 million COSAP grant with the Attorney General's office, as well as supporting the passage of legislation to modernize our behavioral health system in both the 2019 and 2021 legislation. So working together, the board and the coordinator, incurring cooperation between state, local, and tribal governmental entities and other persons and entities that provide behavioral health services in the behavioral health region. Identifying the behavioral health needs of the community within the behavioral health region, evaluate the quality of behavioral health services in the behavioral health region that we support, resolve problems relating to such needs and services, develop plans and objectives relating to such needs and services. Meet with providers of behavioral health services within the behavioral health region and participate in the development and implementation of long-range plans for the provision of behavioral health services in each behavioral health region. Develop cooperative working relationships with law enforcement agencies, providers of social services, advocacy agencies, providers of behavioral health services, and other relevant persons and entities within each behavioral health region. And then perform such duties as requested and assigned by each policy board. We understand that each of our regions are different and all needing different guidelines from our boards. So in summary, following intensive community outreach and research on community-based local behavioral health authority models, the Northern Board identified a drastic change to the governance of our system was premature at this time. There are infrastructure and capacity challenges that can be addressed now to a prior potential change in governance, adding that authority. The proposed language in the first step towards formalizing community and statewide behavioral health systems and sustaining the essential regional behavioral health coordinators. We really looked as a board to really bring a whole community solution to what we were trying to bring to the table. And it really kind of started with that authority language. So we involved a lot of community providers, and each board member kind of took on their subject matter expert in explaining why an authority. And that's when we really determined that we really had to step back and really kind of redesign the boards a bit with duties and things like that to then again move to that authority piece. You guys are going to hear about our BDRs, so I'm going to skip that slide. I was told I had 5 minutes, so I really tried to stay to the facts and stay to the facts. So if anybody has any questions or concerns, this is my contact information, and I apologize for the whole entire slide presentation. I'm not used to Teams.
You did great, Sherilyn. Thank you so much. Anybody have any questions for Sherilyn?
This is David Robick at Bridge. First, I just wanted to say thank you, and you did a really good job of presenting that. So everybody needs good feedback, right? And so I'm trying to give you some. Also, what you just presented doesn't look like what we received in our packets. Maybe I'm wrong.
That is correct. That was the original language that was written for the authority piece. And as we kind of started working on the language and really kind of presenting it to different boards and different communities and community partners, we knew that at that point in time, we weren't ready to bring on an authority for our state. It's something that my board is really kind of looking at, but I think we needed to build the boards up a little bit more with some duties as we start looking at that authority piece. It's a big chunk to take on, and so I think if you come to our board meetings, you'll really kind of hear how our conversation went with that authority piece, and that we as a Nevada weren't just quite ready for that. So I think that's something that we'll be looking at in the next legislation piece as we continue to move towards that piece of becoming an authority, bringing on an authority. Having a bigger oversight than just the state is what we're kind of looking at.
Great. Thank you so much. It sounds like that is it. So we will move on to Ms. Dorothy Edwards for the Washoe Policy Board. Thank you so much, Dorothy.
Hi, can you see my slide? I'm remotely sometimes, unfortunately, does not work. Are you good?
We cannot see it.
So Stacy, you may need to drive your slide that you remediated. Can you set that up?
Stacy?
Hi, this is
Okay.
Stacy Whitkey. I wasn't sure if I was being addressed.
Okay,
Or
sorry.
not. Excuse me. No, that's all right. And so we're looking at which presentation again, please?
It's the Washoe board.
The Washoe board.
Yeah.
All right.
Sometimes my remote does not work with the PowerPoint. And since you had asked us to send you the presentation, I kind of made an assumption. So sorry.
Okay. Sure. No problem. I've got it right here. Let me
Awesome.
see if I'm better at sharing my screen than I used to be. Okay, let's see. There we go. Can everyone see that?
Yes, thank you.
Yes.
Great.
And I'll just kind of tell you next slide. So you have to factor that into my 5 minutes, right?
Sure thing.
I'm down to the seconds here, people. So, all righty, I'll begin. Good morning. I'm Dorothy Edwards. You can put it on slide 1.
Okay.
I'm Dorothy Edwards. I work for Washoe County Human Services Agency and serve as the Washoe Regional Behavioral Health Coordinator. I'm pleased to present an overview of Assembly Bill 69, which expands the loan repayment program administered by the Nevada Health Service Corps to include certain providers of behavioral health care. I'll step through some of the slides quickly, so hopefully you can follow along. Next slide. This is a slide showing current membership. The board meets monthly with the intent to hear from regional and statewide partners and stakeholders around behavioral health issues, practices, developments, and recommendations for change with all of our community partners and stakeholders. The board views all of this information through the lens of support as well as potential legislative concept for the biennial bill draft request. What I believe stands out about Washoe's board and contributes to this success is the composition of professionals who all engage and participate in an equal, trusting, and collaborative manner. Next slide. This slide 3. Next slide. There we go. This slide illustrates the priorities on which the Washoe board has concentrated. This year, as in past years, the board has continued to focus on the crisis response system as the #1 priority, having supported not only our bills, but other pieces of important legislation related to crisis response. It's easy to see how these issues all impact or intersect with behavioral health crises and response. It quickly became obvious to the board that the crisis around the lack of behavioral health workforce was playing a critical role in legislative proposals and regional decision-making. While the Washoe County Crisis Response Implementation Planning Effort, it's a long name, CRISP, is continuing to move forward, it became obvious that we can stand up the best, well-planned, most beautiful crisis facility, but if we don't have the staff at all levels to provide the required services, then we're looking at an exercise in futility. With that in mind, the Washoe board voted unanimously on behavioral health workforce development for their BDR concept. Next slide. Health professional shortage areas, or HPSAs, identify geographic areas, population groups, or facilities within the United States that are experiencing a shortage of healthcare professionals. This slide is just a real small snippet of some data, but it demonstrates the crisis, particularly in mental health professionals in Nevada. Next slide. This slide gives a couple of Washoe County data points demonstrating that 63% of Washoe County residents reside in HIPSA. Next slide. There isn't anything on this slide that's a surprise, and we could probably add more as we think about what's contributed to the lack of behavioral health professionals in Nevada. But for, I would bet all of us sitting on this meeting, workforce, lack thereof, particularly in behavioral health, is an elephant in the room in many meetings. Next slide. So there were many concepts presented to the board to address the workforce crisis, and the entire board listened to them all. We engaged in discussion and collaboration with subject matter experts and crafted and submitted our BDR concept, which was subsequently assigned as Assembly Bill 69. We learned from behavioral health or subject matter experts that existing tuition payment programs must follow strict federal guidelines to achieve federal match. Nevada is no longer competitive with other states offering more generous or more flexible state programs. AB 69 provides additional resources to increase the number of providers as well as flexibility to meet critical needs not covered in the federal program. It expands provider types and care settings and targets a portion of funds specifically to behavioral health providers to meet a critical immediate need. Listed here are the providers included in the bill language. We will be proposing a friendly amendment to add and clarify licensure for school psychologists, social workers, and expand K-12 to add preschool. Not sure this made it to your copy, but I guess since we're doing mine, well, actually, I don't see it on this one. Next slide, please. This slide provides the eligibility commitment criteria. I will not read it for the sake of time, but you can see it addresses the settings, full-time faculty member, the education location pupils, K through pre-K through 12, and then also addresses the payment criteria. Next slide. So, we all know it'd be nice not to have a fiscal note, but to accomplish this legislation, we sought out again our subject matter experts to determine the amount to request one shot that would significantly move the dial on increasing our cadre of professionals and still stand a reasonable chance of passage. This bill assumes an appropriation from the state general fund to the Office of Finance and the Office of the Governor for allocation to the Nevada Health Service Corps of $1.5 million. It's understood that the provision of $50,000 for a 2-year commitment will yield 30 additional behavioral health professionals. And certainly we hope that the legislature decides to continue to pass this. This is a one shot and again, it moves the dial one step forward. Slide 10, next slide. So this is a friendly amendment I've referenced already. Next slide. This is related workforce legislation, and I believe actually there's more going through that we have pledged the board to support and collaborate with as the session moves forward. You're going to hear from our Rural Behavioral Health Policy Board partner. They have an amazing bill program to put forward. We have met with our state treasurer. They have AB 45. It's much broader than our bill. And we'll just kind of see how things morph out. But right now we've decided to watch how it plays out and goes through committee. Next slide, last slide. So we have received a lot of really moving statements and comments regarding the challenge of finding behavioral health professionals to meet the needs of our community. Several of you have sent those to me, and we have included them in our testimony to the legislature next week. But I don't have time to share them, but from law enforcement to public and private agencies and individuals in crisis themselves, the message is the same. We need help. We cannot ignore the cries anymore, and we feel that this piece of legislation is a strong first step to move the dial in a positive direction. Now, not that I don't want to take questions. We love them, but in the interest of time, if you have questions or you want further information, I've given my information. I would be happy to elaborate on anything. Otherwise, I'll turn it over to our next presenter. Thank you, Chair, and thank you, committee, for listening and sticking around for us.
Dorothy, you did a wonderful job of articulating all of that in a quick amount of time, but we really appreciate it. It was a great presentation.
Thank you.
Miss Sarah Adler and Michelle Bennett and Shar Frost from the Clark County Behavioral Policy Board.
Good morning. This
Good
is
morning.
Sarah Adler. I am honored to be working with Shar Frost, Chair, and Michelle Bennett, Coordinator of the Clark Regional Behavioral Health Policy Board. I come to you as a volunteer policy specialist with NAMI, Nevada. And the Clark Board and I and NAMI have been working closely on SB 68. So I am going to hold my breath and here we go. See if PowerPoint Live, preparing your slides, loading your presentation.
Perfect. We can see it.
Are we there? Great.
Yep.
Okay, so I'm so appreciative of my colleagues because they really explained what the regional behavioral health policy boards are. I work closely with them since their inception and have seen the great work that they've done. You've got that background. SB 68, what are we proposing to do? This is a big lift for a big change that we feel strongly is needed, which is to create a revenue stream that will provide ongoing funding to establish and sustain supportive housing. And a piece of that revenue will also go to housing stability, which we think is very important to reduce anxiety, depression, and mental health concerns. We can give more families stability. So I've made a very abbreviated presentation here. So apologies for not being as elegant as Dorothy's presentation. But what is SB 68? It proposes to add 20 cents per $500 of sales value to the real property transfer tax. This is a tax that is already paid. It goes in several places to school districts, to local government. And with that 20 cents, we will create the Critical Needs Fund for supportive housing and services, really creating two buckets, supportive housing and services and housing stability. We argue that this is affordable. This tax would be borne by people who can actually afford to buy property to create housing for people who are currently in encampments, in shelters, being housed by their family members, their aging family members. That's our NAMI situation. So it would cost $160, additional $160 on the purchase of a $400,000 home. Or recently, Microsoft bought 200 acres out east of me in Silver Springs for $16.5 million. It would add $6,600 to that transaction. So that is extremely affordable. The other thing it will do is replace cost that is now going to emergency departments. It's going to incarceration of the mentally ill and the substance abusers. 1 year of supportive housing would cost the same as 3 months at Clark County Detention Center or 11 days at University Medical Center. This will serve, and you'll see if you have a chance to look at the bill, our definition of disabled populations, but that encompasses the unhoused, people with severe mental illness, people in recovery, individuals with intellectual and developmental disability, and their families. So if those folks are residing in a household, families can receive services as well. Also for people who are what we call very low income, which is 50% of area median income or less, and prioritizing people at 30% or less. Shar and I and Michelle, we've been doing a lot of work. We've got done a lot of outreach, a lot of people in what we refer to as the big tent, prepared to support the bill.
here's a single slide sort of overview of how critical needs funds can be used. On the left-hand side of your screen, you see supportive housing. And very quickly, in affordable housing and in supportive housing, there's sort of three legs to the stool. One leg is the actual bricks and mortar. Good news is that lasts for 30 or 40 years. The second leg is enough rental assistance to allow the project to actually pencil in terms of its operating budget. And the third leg is the supportive services funding that is necessary for that type of supportive housing to succeed in sustaining its community in recovery and ideally bringing stability to them so that they can move on into subsidized or market rate housing. We are going to add by friendly amendment the opportunity to use the supportive housing and services funds to acquire existing properties. Think of a disused motel on a main street in rural Nevada, or a small apartment complex, or you all in your larger communities have much larger, for example, the Safari Motel project down in Las Vegas. So we will allow up to $15,000 per unit for what we call acquisition and rehab. The persons with a disabling condition will be eligible to live in the supportive housing and receive supportive services. Over there on the right-hand side of the screen is the housing stability piece. That will be more simply rental assistance and eviction prevention assistance for very low-income people. Also in rural Nevada and sometimes in urban Nevada, some of the very lowest income people are living in a trailer home that they own on a quarter acre that they own, but it lacks insulation, it lacks ramps, it lacks the ability to really be safe and sustainable housing. So home repair funds would be eligible as well. The role of the Regional Behavioral Health Policy Board is every year it will decide these two buckets. I've got to put a minimum of 25% of the available funds in each bucket, and that 50%, where should it go? In rural Nevada, we don't have a supportive housing industry or community established. It's going to take us time to get the wheels on that bus. And so in the early years, I see a lot more money. Perhaps the rural boards may decide much more money goes over here in housing stability. But I do absolutely believe we can create supportive housing in rural Nevada as well. In our urban communities, Washoe County, for example, got big ARPA dollars for the bricks and mortar to create supportive housing in Washoe County, but they do not know on an ongoing basis where are the rental assistance, the operating subsidy, and the supportive services dollars. Very importantly, we see these projects as leveraging and filling gaps that Medicaid can come forward with tenancy supports. Housing choice vouchers from HUD can come forward with rental assistance. This will be Nevada-based money without constraining eligibility criteria that prevent some people from being able to access existing programs. And I'm just going to close by giving a huge shout out, and Roxanne has been on the Zoom here today. If you don't know the Empowerment Center in Reno, this is a jewel. And Roxanne and her team spend a lot of time chasing grants to try and make sure that they can succeed in the two halves of their coin. One is a treatment and what I would say treatment and supportive housing recovery. It's a disused motel that they renovated. The other, they have gone through the low-income housing tax credit process. Oh my goodness, to create Marvel Way Apartments, which is long-term supportive housing. It is sober housing for folks in recovery who need affordability. So I've probably gone through my 5 minutes. I could go on. I have a lot more detail about how much money. Here's something I want to say. Great about the Clark board. I've worked
long time in rural Nevada. And I went to the Clark board and said, unless we give a minimum of $500,000 a year to our rural regions, we will not get the wheels on the bus. So Clark board has generously created a floor of $500,000 annually per regional behavioral health policy board region, and then Clark and Washoe get substantially more. The other thing is that there will be a competitive grants process to get housing developers and social service providers to come together with their proposals. And a regional behavioral health policy board member will sit on that competitive grants review process, as well as some other folks, such as yourselves, with experience in treatment and services, so that we allocate these funds to winning partnerships. So I'll stop there. Any questions? And let me know if you want the whole PowerPoint. I'll send it on.
We would like the whole PowerPoint. That would be great. Thank you, Sarah. That was a wonderful overview. And thank you for highlighting the Empowerment Center. Roxanne, yes, does an amazing job. And we're lucky to have them in our community here in Washoe County. Anybody have any questions for Sarah?
I know where you live, Sarah, so I'll ask you later.
Okay.
This is Esther.
Yeah, full disclosure, I work for Esther and Lana in my other life.
Excuse me, chairs. This is Stacy Whitkey. I've had a request to move item number 9, our problem gambling services update, up because our presenters have an obligation at noon.
How long is their presentation, Stacy?
Theirs is brief. They were asked to be right around 5 minutes or so.
Okay, I still think if Valerie is at 5 minutes, that we can still fit Kim Garcia in.
Okay.
Valerie from the Rural Policy Board. Does that sound okay?
Absolutely. Short and sweet
Okay.
is something I can do for you.
Thank you,
Thank you.
Valerie. We appreciate it.
I'm trying to take my screen down, but I'm not succeeding. So hopefully Valerie will step over me.
I can try.
Thanks.
There you go.
All right, is my presentation up? Perfect.
Yes,
Thank
it
you
is.
so much. Thank you so much, chairs. So for the record, my name is Valerie Haskin. I am the Rural Regional Behavioral Health Coordinator, and I am going to be presenting today regarding a brief kind of touch point on the Rural Regional Behavioral Health Policy Board and AB 37. My apologies to Stacy Whitkey. I did send you these new slides. I did have to change things around a bit. So we currently have a nice full board that's working out really well. We have good momentum, and we are not currently seeking any new board members. My counterparts and I were asked to originally to talk about our funding or board funding per se, and just kind of a quick reminder that the policy boards themselves do not currently receive any direct funding. We get 3 sub grants down to the local level, and those sub grants are awarded to local agencies who then house my counterparts and I, and those are SABG, Mental Health Block Grant, and SOAR. The grant cycle is October 1 through September 30th, and we each have our respective jurisdictions with our regions. The rural region, which I serve, is Elko, Eureka, Humboldt, Lander, Pershing, and White Pine counties. This year, the Rural Regional Behavioral Health Policy Board reorganized its priority areas into 5 broad regions with specific challenges under each. These broad regions include access to care, insurance, workforce development, quality of care, and supporting local efforts. You can find more details regarding each of these within the backup document I provided and submitted. I believe it's already posted as well, which includes a detailed description of these priorities as well as potential solutions to which my board would be looking to support. So moving on to AB 37, we heard a presentation from Dr. Sarah Hunt from UNLV regarding the model for the Behavioral Health Education Center of Nebraska and the successes that the Beacon Center had had. And with that, we have built out AB 37 to really establish a similar center that could be successful here in Nevada utilizing our existing resources. It is intended for this center to act as a robust pipeline for behavioral health providers and would work K-12 through professional practice. So I'm going to be very briefly touching upon each of these 4 segments. So first, as we talk about K-12, there are already a lot of different programs and services in place to help recruit students to different professions across the state. Unfortunately, some of them are not always equal, and a lot of them depend on the school district and the resources the school district has at hand. So one of the things that the center would do would be to collaborate regarding the expansion of career and technical education programming to include behavioral health professionals, working with the area health education centers that are across the state to really start to focus more on those behavioral health professions, and then also looking at how across the state we can bolster efforts to support and include minority and disadvantaged youth in that recruitment process so that they understand that this is an option for them. And then, of course, tying in with existing social emotional learning, or SEL, and mental health support programs that are existing in the school to help students realize that this is the type of work that they can do in these professions. Moving on to NSHE and the higher educational level. So first, the professional programs that AB 37 is going to be looking to affect will include marriage and family therapy, clinical professional counseling, psychology, psychiatry, clinical social work, and then moving into even behavior analysts, all drug and alcohol counselor types, and then the specialty medical tracks, including psychiatric nursing and others. Through this, what we really want to do is ensuring that undergraduate students have the ability to fully prepare for graduate school. And that includes test preparation, ensuring their courses are correct, any internships or other opportunities that might help them become more eligible for high demand graduate school spots. The other big piece is that we want to make sure that there are easily accessible opportunities for high quality, both undergraduate and graduate internships for our future providers so that they have the opportunity to get those hours that they need in order to complete their education. Moving into professional licensing, we also need to make sure that there are enough approved internship sites and supervisors available for students upon graduation, as most licensure types do require additional clinical hours after graduation. Through that, we're going to focus on training and technical assistance for both supervisors and those potential sites. And then, of course, working with the licensing boards to create processes and improve that efficiency. So making sure that everyone's on the same page, speaking the same language, and that the process moves as smoothly as possible. Finally, moving into professional practice, oftentimes providers, when they're looking to set up a private practice or trying to figure out how they go about finding a job, this might be a little bit difficult. We want to make sure that we make it a smooth and seamless transition to practicing here in Nevada so that we keep people and they don't go elsewhere. And one of those things is to work with Nevada Health Corps and other federal programs to help place providers in those rural and underserved areas. And this is where bills like AB 69 from the Washoe Board really come into play and dovetail really nicely with the goals and objectives of this particular bill. We also want to provide opportunities for professional development, including how to set up with insurance, getting liability insurance, business licensing, leadership and management, and other skills that are necessary for having a high quality business or organization or functioning within that environment that aren't necessarily always taught within graduate programs, and they may not get otherwise. And then last but not least, recruiting eligible providers that have completed this program to then be supervisors or sites for those undergraduate, graduate, or clinical internships. With the infrastructure, we don't want this to become another building where money is wasted on a brick and mortar center, but there's no programs. So ultimately, what we want is for the fiscal note that is going to be attached to this to focus on building out the programs and staff. Also, by doing this and utilizing remote technology as much as possible, that enables to ensure that wherever the center lands within the NSHE system, we have better collaboration across different schools and across different parts of the state. It's our concern that if it was just housed at UNR or UNLV, it would be more focused on those programs instead of taking a broad and statewide approach. Speaking of statewide approach, we're looking at a hub and spoke model, much as what Nebraska did, where we would have the main hub seated within probably University of Nevada, Reno or University of Nevada, Las Vegas, and then spokes out to different areas across each behavioral health region that isn't already served with the main hub. These regional hubs will then have specialties on top of providing recruitment opportunities, and these specialties may include telebehavioral health education or other things. So the advisory consortium will essentially direct the executive director and the staff of the center as to what needs to be done, what's working, what's not. And as you look at this makeup that is also outlined within the bill, you'll see that it probably looks pretty familiar. We did model a lot of this after the makeup of the policy boards themselves, and then added in additional seats to make sure that educational systems at both the state and local level and at all levels were included, as well as other representatives. And then finally, our projected fiscal note, because everybody wants to know the dollars. Right now, so this is actually, I thought I had updated this slide, my apologies. So the initial estimate was about 2 million a year for the biennium. We're actually looking at about 2.3 last time I heard from NSHE regarding the biennium fiscal note. So not 4 million, 2.3. And then it would probably go to approximately 2 million a year. And the reason why that's different is because we are anticipating time to build up the center and the program itself. And there's no point in wasting money and just having money laying around for the first year or two while they're staffing it. What we've heard from our stakeholders is that while there may be apprehensions about passing a bill with a fiscal note with numbers in the millions, the time is right, this is badly needed, and we need to make this investment for the long-term health of the behavioral health system here in Nevada. And with that, that concludes my presentation, and I will go ahead and open it up for questions at the call of the chairs.
So this is David Robeck at Bridge Counseling in Las Vegas. If you don't mind, Jolene, is that okay?
No. Yep.
You mentioned quite a bit about self-employed people and not knowing how to do their work and things. I would really love it if you really push for agency work. There are so many jobs, especially in rurals, that need employees there, and they will get amazing training at those facilities. I know we do it. We're not rural, but my colleagues in the rural areas are desperately needing that because we have to support them sometimes, and we're delighted to, but boy, it's very good to support workforce, but a little less on the self-employed because they need to figure it out themselves. They're going to be private businesses, so, and they do not treat the clients that we serve. They never treat the clients we serve.
Absolutely. For the record, Valerie Haskin. So that kind of private practice end is one of the lower priorities as we're looking at how this would flesh out over the several years, but also more so that things that could carry over into all different settings, including management and leadership and communications, would be huge. I mean, we all hope that someone who has gone through professional education to become a behavioral health provider would have great communication skills, but that's not always the case. And it's always good to have additional opportunities to develop those skills.
Thank you, Valerie. That was another wonderful presentation. I think we have it really covered with the workforce and a lot of the other issues challenging our state with all of these bill draft, so thank you so much for presenting to us. Any other questions? Okay, great. Let's move on to problem gambling services, agenda item 9. Thank you, many of you, for staying on. I know we've lost a few, but I appreciate it. I had the pleasure of meeting Kim Garcia in the training, the summit in Las Vegas, and I learned a lot about her work with problem gambling. So take it away, Kim. Thank you for putting it together.
Good morning. Thank you, Chair and members. My name is Kim Garcia, and I oversee the problem gambling services for the state through the Bureau of Behavioral Health, Wellness, and Prevention. And today, Jeff Murata is going to be presenting our problem gambling services. And thank you for moving us around today. We greatly appreciate that. Jeff, and I will turn it over to you.
All right, thanks, Kim. And hello, everybody. I'm so glad that you stuck around for this presentation. It's a long meeting, but we have some really cool stuff to present to you and discuss with you in the next few minutes. starting with just an orientation of problem gambling. Problem gambling, as you might imagine in Nevada, is a issue that impacts Nevada more than most other states. We have a higher rate of problem gambling prevalence than almost any other state in the country. When we think about problem gambling, we often view it along this continuum from a non-gambler to severe, somebody with severe problems. Problem gambler, we're typically talking about those in the moderate to severe range. Somebody who has a clinical diagnosis of a gambling disorder falls in that severe problem range. So these numbers, they, well, with the numbers, with this rate of 2.7 to 4.3% of our population of adults in Nevada having a gambling disorder, it affects individuals differently regarding their specific population that they belong to. So vets have much higher rates, and so do individuals who utilize behavioral health services. The other thing to keep in mind with problem gambling population is that it was thought about as this progressive disorder that kind of moved up the spectrum, but now we know from longitudinal studies that people kind of move around quite a bit. Okay, so the Problem Gambling Service Program, it was established in 2005. There's an account for it. There's approximately a $2.1 million budget for this fiscal year. There's an advisory committee for problem gambling that advises the department on strategic planning, on fund programming, and that committee is a governor appointing committee. It's guided by a couple things. One is the strategic plan. We're working currently on developing one for the next few years, but we do have an active one. It's very informative. If you want to find out a lot more about this system, that's a great place to go. You can find that on the Problem Gambling Service website that's housed in DHHS. And we also have a provider manual that kind of lays down all the specifics regarding providing specialized services to individuals with gambling disorder for the DHHS Problem Gambling Service funded providers. This is what the system looks like. In there's within the large behavioral health and SAPTA system, Problem Gambling Services has its own kind of comprehensive service system that includes prevention, research, workforce development, treatment, information management, and administration. These are the various kind of levels of effort in dollar amount that is placed into each of these service categories. We know from our research that the treatment does work. So people that do attend these problem gambling specialty clinics do have very good outcomes. 98% of them are reporting that they reduced their gambling during our 12-month follow-up studies that take place. We see that there's functional improvements in many different domains, including getting along better with family, doing better at work or school. These are just a few of the things that we look at and are highlighted on this graphic. In terms of the specialty clinics that are out there for problem gambling services, there are currently 5 of them as depicted on this map. They're concentrated in the kind of Washoe County area and the Las Vegas metro area. There's one in Fallon that kind of serves a pretty wide swath for rural Nevada. That also offers telehealth services for individuals that are unable to get there into the brick and mortar facility. So these are our 5 different clinics. 2 of them are residential. The rest of them in the residential clinics, which is Bristlecone and New Frontier, also provide outpatient services. The other ones are outpatient or intensive outpatient only. We have a lot of outcome data. That's one of the great things about this program is, and this is where you can find the report to look at that. I'm just going to highlight a couple pieces. This is our enrollments across the past 10 years. And what you see is our enrollments have gone down, especially as impacted by COVID. So this past year, we saw about 300, a little over 300 individuals within the specialty services, the problem gambling specialty clinics. One of the things that's interesting about the individuals served within the problem gambling specialty clinics is the demographics. So what you'll see on the residential bar, which is the red one, is this looks like a lot of clients that are entering most publicly funded service addiction programs in Nevada, where a high number of them are in the lower social economic status groups. Now, what you'll notice here on the outpatient, with the outpatient problem gambling clients, is the majority of them are actually high wage earners, relatively speaking. So this is not a, where those clinics serve a population that just is not seen kind of in other behavioral or other publicly funded services, which kind of is interesting of itself, in that it's an aberration from most publicly funded service programs in terms of the clientele demographics. We do know that a lot of the folks who come in for services for gambling disorder have broken laws to finance their gambling. We also know that many of them have had suicide attempts. Some research suggests this is one of the highest clinical populations in terms of suicide attempts. And here you could see the numbers reflected in outpatient residential. We also see that this is also a good depiction of differences between the folks who attend the residential programs versus the outpatient, especially gambling clinics. Substance use, there's a lot of co-occurrence, especially within the residential program. The residential program clients are very complex. The ones in our outpatient program, many of them have co-occurring SUD issues, but not all of them. We'll see a large number that come in without any co-occurring comorbid conditions. The folks who do come in, this is another thing that's interesting in terms of differentiating problem gambling, the publicly funded problem gambling clinics from other publicly funded programs, is how many are first-time enrollees. You'll see in the outpatient, 72% of them first-time enrolled in treatment services. The majority do have a very severe form of gambling disorder. They would meet the clinical criteria for gambling disorder at the severe end. Some of the new efforts we have going on, and the reason they're new is because, as we mentioned before, there's only about 300 people that are being seen in these specialty programs. So we need to find a way to bring these very effective services to more individuals in need. There's a problem gambling awareness campaign. It's called Project Worth. There's the link to it. There's some really kind of interesting stuff in there. It's meant to be engaging to increase awareness of these services to the broader community. We're also very excited about a problem gambling integration project. Now, what this is doing, it aims to utilize the existing infrastructure of addiction and behavioral health programs in Nevada and provide a program to increase their capability to work with gambling disorder individuals who are already in their sphere of care. And so we think this program makes a lot of sense because, as I mentioned earlier, there's a high degree of co-occurrence with SUD and gambling disorders. We also know that individuals in SUD treatment with gambling disorder have poor outcomes, and SUD populations are at increased risk for developing gambling disorders if they leave and the addiction switch afterwards. So that we think that this is going to improve client outcomes for all clients that are engaged in these programs that have this newly developed endorsement as a co-occurring, as a gambling co-occurring disorder program, SAPTA certified program. You can learn a lot more about problem gambling. There's a couple of great conferences coming up. There's also ongoing trainings that are available through CASAT. They're really high quality. Recommend those. The Nevada Council on Problem Gambling is a wonderful resource site, as is the Nevada's DHHS Problem Gambling Services website. Lots of good information there as well. And with that, if there's any time for questions, we could take them or reach out to us if you want more information. This deck isn't available in your handouts, but will be available following this meeting. Thank you.
So that's David Robeck from Bridge, because you guys aren't tired of me yet. I was just kind of curious, Bridge is not listed in the providers list, although we do still continue to have licensed staff and still provide those services. We just do not request funding directly for gambling anymore.
Thank you,
Yeah,
David.
that's correct. Those 5 clinics only represented those that had specific grants for problem gambling treatment. And there's many other programs out there that will provide problem gambling and gambling disorder treatment.
Well, I think that's important to include, just as a thought.
Okay. Thank you so much, Kim and Jeff, both. Appreciate the presentation. We haven't actually talked about gambling counseling for a very long time in this meeting, so I think that was really valuable.
Thank you.
Okay, let's move along. Agenda item 10 is the topics for the next meeting. I have outlined what we did not get covered today or things that we need to follow up with on the next meeting. Feel free to jump in, Jamie, if I missed something, but we had the Partnership for Success. I think Tracy Palmer is going to revisit some stuff there. The SOAR 3 CASAT budget breakdown, is that correct? Okay, and then a co-chair report, and then also Lori Follette for the CCBHC funding that we wanted to hear all about. And did I miss anything else? Oh, Lana has her hand up. Hi, Lana.
I got to find my mic button. The one thing that kind of threw me off a little on today's agenda is that the standing items that have been on our agenda forever are missing.
Yes.
And that would give us the update from the Bureau, not just on the one topic that Shannon covered for us. It would also include an update from CASAT, you know, all of those, and the co-chair report or statements were also included in those items. So I'm not sure if they just fell off in the process of developing this agenda, or if they were left off because of the length of the agenda, because this agenda was really aggressive and long in order to really be able to cover all of the things that we had. This was probably a stretch. But anyways, I'd like to see those standing informational items come back with more of an update from SAPTA. One of the things that I'd like to see addressed on the next agenda by the SAPTA team and is the 1115 waiver that is going to allow Nevada Medicaid to be able to pay for residential treatment within certain parameters. I believe that they're in discussions right now to talk about the fee schedule, how they're going to handle it. You know, all I'm getting is feedback, bits and pieces, that residential services, they're proposing an unbundling situation and not the 1 day, 24-hour reimbursement model. I also remember from prior discussions when the 1115 waiver was being proposed to CMS years ago, and all of through that process, that Nevada Medicaid can't pay for room and board. And I remember Dr. Woodard standing on record at one of our advisory meetings before COVID, because we were all in Carson City around the table, that the current reimbursement that SAPTA was giving for residential services would then cover the room and board piece. I know this is a big deal for us residential providers, so I would like to see an update on that particular topic at the next meeting. Thank you for allowing me to speak.
Thank you, Lana. I really appreciate your feedback on the missing agenda items. I just think there's been some turnover and change and that those items just got left off. I don't think it was intentional. And today's, under the best of circumstances, today's agenda could have never happened. So it will look much different next time. And I think we have plenty for the meeting on April 12th. So I'd really like to not put any more topics on there, if that's okay with people. Okay, moving on to item 11. Is there any public comment?
Yes, there is, Madam Chair. And
yes, Esther.
I checked with our CFO Dottie and I said, just that kudos to SAPTA. Money will be in the bank tomorrow for January. Kudos to SAPTA. Congratulations, because I asked if we are submitting through the portal for RFR now, and the money will be in the bank tomorrow. So congratulations, ladies. Congratulations to us too.
Yes, that's a win for everybody. Thank you, Esther, for pointing that out.
Yeah, because that's right. So thank you all. I wanted to stay on for that. Thank you.
Awesome. Any other public comment? The next meeting is April 12th at 9 a.m. And I think we can adjourn the meeting. Thank you all for sticking around. Really appreciate it.
Thanks, everyone. Have a great
Have a
day.
great week.
Have a great
Bye, all.
day.
Bye, Leah.